Nu.
Test, 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 2, 2. E bine? Da, văd că se duce acum. Test, test.
Da. De ce nu se poate conecta totuși de pe laptopul meu ca să văd?
Test, 2, 2.
Pentru că nu au
Test, 2, 2, 2, 2.
conectare aici.
Eu am întrebat aseară.
Nu știu. Îmi pare rău pentru...
Deci,
Test, 1, 2.
Trebuie luată de la cap. Și atunci...
Test, 2, 2, test. Test, 2, 3, 4. Doi, 2, 3, 4, test. Înseamnă că e... Test, 2, 2. Test, 1, 2.
Acum de la minus 21. E ok, e ok, da.
Test, 2, 2. Lăsăm așa. Test, 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 2, 2, 2, 2, 2, 2, 3, 4. Test, 1, 2, 2, 3, 4, 4, test. Cum e? Bine?
Nu știu, să vedem. Mă stați un pic. Cum salvez asta? Deci nu-mi vede video. Nu. Și nu se pot cupla. Save as a picture. Stați un pic acum. Lăsați că acum mi-l fac eu pe mine. Deci, eu am întrebat. Gata, lăsați că îl fac pe draft și e deschis încă e-mail-ul meu de acolo.
So good afternoon and a very warm welcome to the first SGRT community meeting here in Bucharest. This is in collaboration with Onco Systems. I would like to thank you for taking time out of your clinical commitments to join us here this afternoon. A special thank you as well to our speakers, both local and international. My name is Wesley Naidu. I'm the Clinical Applications Manager at VisionRT. I just want to give you a brief overview about VisionRT, where the company started, where we are today, and just a little background as to the purpose and the main aim of these SGRT community meetings. VisionRT was founded in 2001, so it has been the pioneer of surface-guided radiotherapy as you know today. VisionRT is headquartered in the UK, in London, with more than 250 employees. Majority of the team are in research and development, which is a strong focus for the company itself. VisionRT has deployed systems globally. We have up to 2,000 systems now within the field in clinical use, and that allows just real-time feedback for intrafraction motion management, as well as enabling a good patient and accurate patient setup. Our aim here at VisionRT is to ensure that surface-guided radiotherapy is the standard of care and available globally at centers that are offering advanced treatment techniques. VisionRT is the market leader in surface-guided radiotherapy and actually one of the founders and pioneers of this technology. And we continue to innovate and develop to ensure that we meet the highest standard possible. A component or strong focus of VisionRT as well is the education component, and it's exactly what we're here today to hear from your peers, to share information, to gain new insights, and to implement this into your clinical practice. We continue to, like we said, we continue to innovate and to develop, introduce new technology into the market. Later on in my presentation as well, I will show you what is currently available and what is to come. VisionRT has been awarded the Queen's Award for Innovation, for Technology, and we, like we said, we just continue to pioneer and innovate new technology. So what is the core vision here at VisionRT is to establish SGRT as a standard of care for motion management and a must-have in advanced radiotherapy centers globally. So how do we achieve that? Through technology leadership, and like we mentioned, we have a strong team focused on research and development to ensure that we enhance the existing products as well as introduce and create new products to the portfolio. We want to expand globally and ensure that we have and collaboration both directly and through our partners and distributors in different markets like Onco System and various leaders worldwide. Again, strong focus on technology and education to ensure here that we are sharing knowledge between our peers. And Vision IT is, of course, the standard of care for SGRT. A little about the SGRT community. Like we mentioned, the purpose here is to exchange best practices, to share the information between colleagues and peers so that you not hear just from Vision IT, but also your colleagues in the field. You can get feedback, you can ask any questions when you're implementing the technology for the first time. And we run continuous programs, webinars, workshops to ensure that we keep up to date with the current developments. The SGRT community meetings are held globally at different locations. There are online webinars, in-person attendance, and together with the Astro shows, we will have meetings in conjunction with those major conferences as well. Globally, it's quite a strong community of 11,000 plus users currently. So again, you have an open platform to ask questions to your peers, to have their feedback and their experience of implementing SGRT into clinical practice. It is independent. It is funded and supported by Vision RT, but an open platform. It's usually chaired by an independent chair. And like we mentioned, these meetings are held globally at different locations. The next one is in the US, and we are looking at then other local meetings in developing and emerging markets. I would encourage you to join the SGRT community. So it's www.sgrt.org. It's free to join and you have access to publications, past presentations. You will be alerted to any upcoming webinars and that content is also available on demand. The agenda for today, so we have various talks from our invited speakers. And I'm going to hand over at this point. You have also access to this agenda on your printed card on your table. At this point, I'm going to hand over to Prof. Alina Mihai from the Beacon Hospital in Dublin. And Prof. Alina is going to share her experience with improving the accuracy and patient experience with SGRT. Thank you for your time, and I wish you a good afternoon and presentations.
Hello. Thank you to Vision IT and Oncosystems for inviting me to speak. It is always a pleasure to be here. And over the next 30 minutes or so, Gabi, could you please show me when I have 5 more minutes left? I would like to share with you our experience in Beacon Hospital with the accuracy and patient experience using surface guidance. I'm a consultant for Vision RT and I am presenting on this. Okay, so we know that over the last 20 years or so, there were significant advances in radiotherapy. We are now able to deliver very conformal dose distributions, which is good because we can deliver very high doses of radiation, but it is also a reason for, can be an issue if we have geographic misses resulting in significant toxicities. And we know that technology helps, but one of the sources of error is patient positioning and patient movement. Surface guidance is now widely accepted in radiation therapy facilities, and it is mainly used for positioning of the patients and monitoring during and before the treatment. And recently there are developments in the gated treatments. We are not there yet, but hopefully will be soon. Why do we need surface guidance? There are several systems available, but today I'm going to speak especially about Align RT. It is used for patient setup. It is a non-invasive, non-ionizing 3D real-time type of monitoring. It has a very accurate isocentric setup with less than 3 millimeter accuracy in translations and less than 0.2 degrees in rotations. Can be used for intrafraction monitoring, allows 6 degrees of freedom motion monitoring in real time, which allows automatically switching off the beam off and on if the motion is above a preset threshold. It increases patient safety and comfort, and we are going to see it soon. And hopefully, it will improve the clinical outcome by allowing better targeting and better sparing of organs at risk. Align RT, you can see here an overview. It's a non-ionizing, non-invasive method of monitoring. Images the surface and not the tumor. So this is one of the most important messages today. It consists of 3 mounted cameras, as you can see here in a triangle, and a visible light projector, as you can see it on the surface of the patients here. The system creates a 3D surface model consisting up to 20,000 points and uses regions of interest, which will be used for monitoring. And this can be either a CT SIM contour body surface on CT, or another Align RT from a system already installed on the CT, or a previous Align RT image from a previous session. You can see the screen that the therapists are using. This is the area of interest, and these are the suggested translation and rotations. Very easy to see. Green is good, red is bad. The registration algorithm tries to minimize the distance between the reference image and the real-time surface. The most important probably part of the process is the region of interest selection. And this is absolutely critical. You have to choose, regardless of the area that we are treating, you have to choose a stable portion of the skin surface, avoid large unstable areas, parts which are not part of the patient anatomy, such as gowns or immobilization devices, or non-reproducible areas due to motion. So you can see here how we recommend the choice of the OARs or ROIs based on the thorax, pelvis, or abdomen areas treated. Align RT has also limitations, and you have to be aware of them. The 2 lateral cameras are blocked for a very short time during the COM-beam CT acquisition, so will not capture the patient motion. So it is very important to record the patient position at the beginning and at the end of the COM-beam CT. The workflow is simple. The only difference with the regular type of workflow is that the DICOM-RT image of the surface of the skin is exported to Align RT system at the treatment machine. The QA is done daily by the therapist and pre-treatment by the physicist. And at the time of the treatment, the patient setup and imaging and patient treatment remain the same. The clinical indications of surface guidance radiotherapy are increasing. It was initially used for the intracranial setting, SRS and whole brains, breast and chest wall irradiations, and you are going to hear a little bit more about this. Deep inspiration breath hold treatments, not only for breast, but also for other sites. Hypofractionated treatments and respiratory management, hopefully for pediatrics, and it will be extremely important for adaptive radiotherapy. I'm going to talk a little bit about these 4 indications shortly. We started using SGRT in 2014, initially for intracranial SRS, for setup intrafraction monitoring, and we treated since then more than 800 patients. In 2018-19, we introduced the deep inspiration breath hold tattoo-less technique for breast patients. We have almost, probably now at this time, more than 400 patients treated. And in 2019, we also introduced it for the extracranial stereotactic ablative radiotherapy, abdomen and thorax, and we have more than 3,000 in our department. We are quite a small department to machine, Ovarian Edge, and Ovarian Trilogy. So I'm going to go shortly to the indications. Now, this slide doesn't project very well, but this shows you that since 2006, we have guidelines for the occurrence of cranial SRS. And ACR Astro Practice Guidelines in 2016 recommend the imaging, planning, and treatment typically to be performed in very close temporal proximity. You need to be accurate within 1 millimeter, which means that we have very little room for error and very strict protocols are required. We started our SRS program in 2007, and since then we have the largest cranial series outside the US using Align RT. We are reference center for Vision RT. The majority of cranial SRS are for patients with brain metastases, but we also treated benign lesions such as trigeminal neuralgia, meningiomas, and vestibular schwannomas. Our program is a Linux-based SRS program with variant Trilogy TX with HD, MLC, and CONS. Initially, we used the Varian real-time optical guidance system, as you can see it here. The problem was that in 2014, they stopped supporting technically the system, so we had to investigate other solutions. These two types of monitoring of the patients are quite cumbersome. First of all, for the frame, you needed a neurosurgeon on site, the planning and treatment done in the same day, uncomfortable for the patient. This type of mouth bite was not easy to be used in patients who are edentated or in children, so there were several issues. We had to choose a new solution, so we had two solutions, Align RT1, BrainLab XRT the second, and we looked at the cost, installation, downtime, method of alignment, non-complainer angle, 6 degrees of freedom, and patient comfort, and we decided to go for Align RT for several reasons. First, the cost was significantly lower. It involved little construction work, and it used the open face mask, which is significantly more comfortable for the patients. The installation was quite quick. Vision RT had a room survey a month prior to installation. In the beacon, we installed the mounting plates for cameras. The cameras were installed directly by the engineers from Vision RT, except over the weekend. The acceptance testing was done on Monday. First patient was treated the same week. So very, very quick installation, while with BrainLab would have been at least 2 weeks downtime for the machine. For the simulation of the cranial patients, we are using Micromedic DSPS open face mask, as you can see it here. What we recommend is to ensure that you have enough face outside the mask, so you can define the region of interest, and the occipital part of the mask has to be deep enough so that the head is stable. We recommend 2 fingers between the mask and the plate to ensure that this is deep enough and stable for the patient. As I mentioned previously, the choice of region of interest is critical, is the primary source of error when you use the Align RT system. You have to exclude the mask. You have here a definition of the ROI. Should only include rigid structures, so exclude the cheeks, especially in patients who are on steroids. Be careful how to exclude them because they are puffy, so they will not be good for ROI. And we recommend to use the frontal bones. We also had issues with patients who had makeup, false eyelashes. So the system gets crazy, doesn't know how to behave in patients with false eyelashes, bushy eyebrows, beards, and so on. So we recommend the patients to shave before the treatment. One of the questions, obviously, was how stable is the open face mask. So we looked at 78 fractions and measured the differences before and after the cone beam CTs. What we've seen that we needed to re-cone beam CT only 5 patients due to the motion during the cone beam CT or the matching of the images. And you can see here, so these are the translations, these are the rotations, that most of the differences are less than 0.3 centimeters and less than 0.3 degree rotation. So the patients are stable in the mask, they don't move, and furthermore, they are very comfortable. They looked also at the cone beam CT versus Align RT, and you have the frequency of translations and rotations. And you can see again that the magnitude of the translation, of the difference between the cone beam CT and the line RT is small, less than 2 millimeter in translation, less than 0.5 degrees in rotation. They looked, our physics team is very, very active, so they looked also at the location for which a pitch was applied, more than 0.5 degrees. And what they seen is that occipital lobes and cerebellum obviously are more sensitive to the pitch. This could result, if you don't apply, this could result in missing the target. You can see here the target, the PTV around, and the target would have been at the edge of the PTV. So if you wouldn't have applied the pitch, then you would have missed part of the tumor. It is important to remember also that after you apply the shifts shown to you by a line RT, you have to re-image with cone beam CT and confirm the shifts are correct. Does the line RT replace cone beam CT? No, and I just shown you the image. The cone beam CT remains the gold standard for localization of the tumors. The SGRT is complementary, is not an alternative to cone beam CT. You can use it for patient positioning and initial setup, monitoring for intrafraction patient motion, reduces the imaging dose and reduces the anesthetic beams needs, but does not replace the cone beam CTs. This was a very interesting case which showed the flexibility of vision RT system. So we had a patient, 52-year-old claustrophobic female with metastatic breast cancer, treated in 2018, presented with this tumor. We wanted to deliver 24 grays in 3 fractions. However, she was unable to tolerate the open face mask. So we decided to go only with the occipital part of the mask and monitor using the vision RT. It was an incomplete immobilization. So what we've done, we increased the PTV margin to 5 millimeter and reverted to standard fractionation. And we monitored real time the patient position. And you can see here, in fact, this is the time of the imaging. And then the patient was very, very stable, very, very little shifts from fraction to fraction. So it is possible to monitor the patients using this system. Because the system is so stable and flexible, we can now use it for treatment of multiple brain metastases in single plants. As you can see here, like there were 11 metastases. We treated several per plan, per arc. The ISO center, what you have to be aware is the ISO center is away for the treated area, so it is extremely important to monitor the rotations and apply them. And this was a patient for whom the optic nerve would have received more than tolerated dose of 8 grays if the rotation wouldn't have been applied. So monitor the rotations of the patients, especially in multiple metastases. In our center, we allow translation of up to 1 millimeter and rotation 0.3 degrees. Otherwise, we reset up the patient and we restart. Since September 2014, we treated more than 800 patients, largest series in Europe. It was well tolerated in more than 98% of the patients, and we maintain very similar tolerances with the optic guidance platform from Varian. Now, breast chest polyradiation and deep inspiration tattoo-less technique. So I can say that the tattoo-less part of this is not, for me, is not the most important part of, or the strength of the line RT system. I am quite skeptical, especially in the context of patients surviving for a very long time, coming for irradiations, and how are we going to reproduce if you don't have the same system? So for me, the strength of a line RT is not the tattoo-less technique. But we implemented this in 2018. And because I am so skeptical, the team had to compare the two techniques using the RPM system as we used to do it. So you have here a reflective block, which was a surrogate for the lung filling, does not track the patient motion. You have to retrack each time when the patient moves or you do changes. Between 2018 and 2021, we used the AlignRT. Simple, tracks the breast tissue, as you can see here, is highly accurate and is able to identify, this is important, is able to identify the bending of the back of the patient, because we know that at least for the first 5 treatments, the patients are anxious, so they bend, and you are not going to see this without a system like AlignRT. And since August 2021, we are using AlignRT Advanced with postural video. You can see the lines. The therapists absolutely love it. The setup is much easier, and you can see much easier the motion of the patient just looking at the lines. So they compared the RPM system with the AlignRT. We had a variant RPM, you needed tattoos. We had more than 10 years experience, so they looked at the 10 patients treated in 2018, and they compared with the tattoo-less technique, auditing the first 10 patients, and then re-auditing after 1 year, and they compared the magnitude of the shifts, the total treatment time, and the number of reset-up, especially for the 3 fields breasts. We know that the supraclavicular setup can be quite difficult. So the magnitude of the shifts, they compared the vertical shifts and lateral and rotations. In blue, you had the RPM, in SGRT in orange, and in green, you have the re-audit at 1 year. What we want is the magnitude of the shifts to have a peak around 0 millimeter. And as you can see, the SGRT performs better than the RPM. And at 1 year, we still have a learning curve, like we still have the lateral splash here of the shifts, but SGRT performs better than RPM in monitoring these patients. So SGRT is more reliable for the patient setup. This is very important, especially in departments which are busy. So what we've seen is that using the SGRT for setup, the treatment time was reduced from 15 minutes per patient to 10 minutes per patient. I know that this doesn't sound a lot, but if you have 100 patients to be treated in 1 day per machine, it is quite important, every saving of the time. And when we looked at additional setup requiring imaging, was unchanged for the 2 fields breast, which we expect because the 2 field breast is quite easy to set up, but AlignRT performed better when we look at the setup of 3 fields breast. Yielded a better supraclavicular setup, and intrafraction monitoring has not revealed patient motion during the treatment. So these 2 points are important: treatment saving setup time and improving the setup of the supraclavicular fields. This is a clear example where the postural video helped. So as you can see in day 1, we use no postural video. You can see the arm in the radiation field. It would have been very difficult to reposition the patient and to require significantly more imaging. We use the postural video, and then you can see day 3, the arm is not in the radiation field. So this helps the therapist with the setup. They love it, absolutely love it. So in our practice for breast and deep inspiration breath hold, the SGRT yields improved accuracy with reduction of the magnitude of the shifts required. It results in reliable setup. So is daily imaging still required? So I think yes. So I don't think that we are there where we just don't do imaging and we use just the monitoring. Faster setup, saving on average 5 minutes per patient. Tattoo-less treatments are more patient-friendly, even if I told you my reservations. Improve the safety standard with real-time intrafraction monitoring, and the staff has a very positive experience, is user-friendly, and is easy to implement. Now, we use it for SGRT and hypofractionated treatments, and I think that this is one of the strengths of this system. Why? Because we are delivering high doses per fraction, very conformal, very high risk of geographic miss, so which can result in significant toxicities. There are longer treatments, so it is a potential for patient movement. These treatments require rigorous image review at the time, So this is time-consuming process, again, longer than standard image review. So again, potential for patient movement. And we also have to consider other factors which are provoking patient motion, such as sleeping, sneezing, coughing, hard couch top, unnatural position, room temperature, and so on. And we know that with the RGSS, which was the system from Variant, does not have patient motion functionality. So you would not catch the motion during this time. This was a very, very interesting case. A patient of mine who was treated for a sternal metastasis, as you can see here. We plan to deliver 18 grays in one fraction with an SIB of 22 grays in single fraction. The patient was set up and the line RT was used to monitor the patient, and we detected this peak here, detected motion during the image analysis and treatment delivery again. We done again the KV pairing and cone beam CT to confirm that the patient moved. If we wouldn't have seen this motion, the target would have been missed. This is what it should have been, 22 gray. This is what would have been done if we wouldn't have seen the motion. So it is where the strength of SGRT is, monitoring the patient's intra-fraction. For SBRT, they looked at the absolute difference between the cone beam CT shifts online and the line RT for 87 SBRT fractions, both in translations and rotations. And again, the strength is like the shifts required using a line RT are small, less than 0.3 centimeter in translations, less than 1 degree in rotation. So since we have this good data, we started to use it for in January 2019 non-RPM stereos, all the sites except thorax and abdomen for intra-fraction monitoring. In February, we introduced it for end expiration, breath hold for abdominal SBRT, synchronized with RPM. Since June, we are using it for standard IMRT and 3D conformal treatment, again, localization and intra-fraction monitoring. And we aim in 2021 to synchronize for breath holds and monitor gross errors. So it is a very flexible system. You can use it in all sites if you know the strengths that the system has. For the tattoo-less technique, again, Greg knows my opinion about tattoo-less techniques. So why did we want to use it? So it was introduced, I think that our therapists went to Genesis, I think in UK, and they came very excited about this. So I asked them, can you show me please that you can use it? Because in my experience, the patients don't really complain about the tattoos. So they assessed the efficacy of a line RT surface guidance as a setup tool to monitor the intra-fraction motion with the tolerances of 0.3 centimeter in translation, 3 degrees in rotations, and to see if we increase the safety when delivering the SBRT doses. So they record the shifts indicated by a line RT following setup, indicated by the OBI system following the setup, and they checked the correlation between the two. So you can see here the T-graph. I don't know how well you can see it in the back. For 15 patients, 15 fractions, sternum and ribs. Usually we use single fractions for these ones. For pelvis, they looked at patients with prostate cancer and they recorded the shifts. And for the abdomen, we usually use 5 fractions for stereo. So what you can see again, the magnitude of the shifts is small here, regardless of the site. When you monitor, less than 0.5 centimeters, regardless of the size. So it is safe to deliver these treatments using monitoring with a line RT. What we also have seen is that the heavy bleeding causes rotational and translational differences. So this improved following the ROI education session across all sites. And for the chest and abdomen, we've seen a vertical discrepancy when there is not enough lateral topography. So be careful when you choose the OAR laterally, when you have the bag, with the immobilization bag, which can mask and limit the delineation of the ROI. So and this brings me to my conclusion. Based on our experience, the top 5 benefits that we've seen from using this system in our practice was improve efficiency, reduction of patient localization time, improved accuracy and reduction of the shifts magnitude and reduction of the gross errors that we would see, improve the consistency of the breath hold treatments, improve the safety standard when we are using real-time intrafraction monitoring, and please remember that's thermal case if you can, and improved staff welfare because it is a reduction in the time of patient manipulation, and we know with the COVID what issues we had. And the staff also reported a reduction in the wrist and back pain, which is important, and they find the system very, very user-friendly and very comfortable, and they absolutely love it more than, and they are the ones using it the most. So thank you for your attention. I hope that I gave you a flavor only. Because I could have spoken probably one day, but at least a flavor of what the system can do. I would like to thank my team from the Beacon Hospital, absolutely amazing team, and especially our physicists and the therapists which are involved in the development and implementation of this technique. And thank you all for your attention and for being here. Any questions? Do you have any questions, or can I introduce the next speaker? Okay, I was clear enough, good. So it is my pleasure to introduce Professor Kocho from Cluj. I know Gabi for more than 20 years or so. He was the first one who taught me radiotherapy and showed me the first CT image. He is now the director of Amethyst and professor at University of Medicine in Cluj-Napoca. Gabi.
Good afternoon. Thank you, Alina, for introduction. I'm happy to see you again, some of you. Some others are the first time I'm getting in touch with you. So yeah, we were missing these live opportunities together to discuss science, and not only that. And especially in such a nice venue, we thank Vision RT for making it that happening today. So yeah, could I have my slides, please? Okay. I send the presentation, but I can run them from my laptop. We're going to start with deep inspiration. Yeah, sorry about that. So I am clinical oncologist working in Cluj. I have both specialties, medical oncology and radiation oncology. And I'm the head of the radiotherapy oncology department at the Medical University of Cluj, and medical director of Amethyst Romania. Just a few words without advertising Amethyst. We are a strong European chain which operates clinics in UK, France, Austria, Italy, Poland, and of course Romania. The project started in Romania, and we are proud about that. The Bucharest team were the first ones, and then we expanded to all across Europe, and we just added one clinic in Germany. That's non-official. Okay, thank you. Let's hope it's working. So I'm going to speak today about, I don't know, the title is not there, but you can see it in your program. So it's about deep inspiration breath hold technique in breast cancer. Just a quick overview of what radiotherapy does as a benefit in breast cancer radiotherapy. So we all know the advantages and indications in decreasing the local recurrences, the regional recurrences, and proving a benefit in survival. And that's true also for breast conserving surgery. So even if it's in situ or invasive ductal carcinoma, and also for post-mastectomy therapy. And this translates into better cancer-specific survival, but when it comes to a price of toxicity, in order to be benefit in overall survival, you need to keep the toxicity as low as possible, of course. And this is particularly important for in situ carcinoma. We are all doing radiotherapy in adjuvant setting after breast conserving surgery without any benefit in survival. The single benefit, it's decreasing, halving if you want, so decreasing by a factor 2, 50%, the risk of recurrences. Whether it's in situ or invasive doesn't matter. But the key message is that a technique that is not improving the survival, but decreases the local recurrence is good as long as the toxicity is very low. When it comes to invasive breast cancer after breast conserving surgery, we know that age and grade are significant prognostic factors justifying even more dose to the breast. The boost, which is used below 50 years, and depending on the age, we can top the boost at 10 grays or 16, or sometimes when it's a very young patient, very aggressive biology, especially grade 3, maybe even more than 16 gray, as was in Harry Barteling paper, ERTC trial, would be of interest. So you see the percentages roughly are a factor of 3 on the benefiting of boost. When it comes to post-mastectomy treatment, for local recurrences, you have 10 years differences at 10 years and 20% differences at 20 years. If you look only for local recurrence, if you add the regional recurrence, it's, let's say, 3 times higher in the absence of radiotherapy, positive nodes, cancer patients, and on the long run, it translates into an overall survival benefit of 5%. So the rule of 1 to 4, it's easy to keep in mind. If you have 4 times less recurrences, that will translate into a significant benefit in survival. This is another trial. So it's Breast International Group trial, which looks to the small tumors with N1 disease. And you see the difference of radiotherapy, it's not as big as you would have expected, but the rule 4-to-1 applies. So if you have only a 4% or less local recurrences, that will not translate into a benefit in survival, or at least significant. So 1% in survival, and you see the overlapping of the Kaplan-Meier curves for that. So that brings us, okay, we are doing something better, at least in terms of local recurrences, but with no benefit in overall survival, we have all interest not to increase the toxicity, especially the lethal one. And one of the most important organ at risk is the heart, of course. And it was already proven, even if it's radiotherapy of the previous millennium, so these are more than 2,000 of patients treated in Sweden and Denmark, from 58 to 2001. And they were picking up the records of them, and there were almost 1,000 of major cardiac events, myocardial infarction, coronary disease, and so forth. And they were showing there is a linear increase of toxicity, of significant heart toxicity by 7 roughly percent per gray of mean dose to the heart. So it starts upfront from a very small dose and it's linearly increasing. So you have to strive to deliver as low as possible mean dose to the heart. Still, this is a paper published 1 month ago. We lack of significant endpoints in our ongoing trials, because afterwards they were saying, okay, this is old radiotherapy, now we are much better. Yes, probably. Prove me the data. Because, of course, we improved our techniques of radiation therapy as to previous millennium. But until then, until we have data, we know that for measuring the function of the heart by SPECT imaging, using deep inspiration, and I will show you our results also, is much better than in free breathing regarding the function, the myocardial perfusion measured by SPECT. And you all know the atlases of organ at risk, how we can subdivide the heart in several compartments. Especially of interest is the left anterior descending coronary, which is between the right ventricle and the left ventricle. Both ventricles are close to the left breast. And when it comes to the right breast, heart is not important, but liver might be, especially for big breast, which is pendling to the lower limit in the projection of the liver. So also can be interesting. And I remember the first IMRT VMAT plans that we did, and we were having tough times in order to ensure a coverage, especially if we had the internal memory chain, without passing the mean dose, which was positioned at 5 gray for the heart. And if it was a bilateral breast cancer, it was even worse. So we were happy when we installed the Align RT, even if we knew already by that time that we have alternatives in prone position, or also the partial breast irradiation techniques, whether by external beam or by brachytherapy, but those are very few indications which patients are let's say, enrollable in those type of partial adjuvant breast radiation. And it's simple to understand. In deep inspiration, there is interposition of lung tissue, and the heart, it's moved far away from, imagine, the tangential field. And this is true for any active breath control technique. So you see the mean dose and the left ventricle, the red ones are in deep inspiration or other active breath, whereas the blue ones are the free breathing. And if you superpose some isodoses, you know that you see that the coverage is still good. So you are not jeopardizing the coverage, but you are decreasing significantly the dose to the heart, and especially to the left anterior descending artery and to the left ventricle. This is a picture that we took in motion. So you see how the heart is moving from the, let's say, a static position in mid-inspiration, let's say, to the deep inspiration. Of course, the lungs are much bigger, they are inflating, and the heart is moving to the midline, if you want, and getting lower, leaving the breast far from that. Professor Mihai already emphasized on several occasions the advantages, and I will point your attention to this word, safety. That's very important for radiotherapy, to deliver safe irradiation. This is the mission of Astro and Astro also. Of course, the others advantages, and it's related to the intrafraction motion ability to track and to see and adjust in order to get to that safety, on top of decreasing margins and comfort to the crew, the medical crew, and to the patients So as member of the board of Amethyst International, and for a couple of years I was the chief medical officer, we decided to install in every country a different type of organ motion, let's say, device. So I ended up, and I'm happy for that, in Cluj with the Align RT system. In other countries, we have other systems. So we already use it for almost, or now we are at 3 years. We are closing to 300 patients. We are not comparing with thousands of patients that you have, but we hope to get there. And of course, we already had the 4DCT and CBCT on our machines, and we decided to start with deep inspiration breath hold technique. But at the same time, we started the stereotactic program, and progressively we used also Align RT for that. This was our workflow, is already also today with the couching part, the simulator, free breathing, deep inspiration breath hold if the patient is able to keep the breath hold for at least 20 seconds. We had specific, let's say, eligibility criteria. Of course, the constraints for the organ at risk, the generally one, and then to set up treatment. And of course, as Professor Mihai said, the RTTs are very important in, so our colleagues which are actually running on an everyday basis, the treatment are of tremendous importance. The region of interest, it was clearly show how we choose it, of course, comprising the sternum, so fixed, let's say, anatomy as possible, so as fixed as possible, and not into the arm or of adipose tissue folds and so forth. And it's important to underline that the region of interest are same for free breathing and deep inspiration breath hold, but we are going quite down here in order to capture the whole breast. Sometimes it's getting a little bit downer. And yeah, the vision, the 3 cameras which are installed in the LINAC with the sensors and the patient, let's say, monitor if you want, so the patient is couched how to inspire and keep the breath until it gets red in the middle of that small device that it's depicted here. So the patient is looking at it, and they are very easily to coach, and they understand very quickly what they have to do, and they are happy to participate, actively participate in their treatment. They feel somehow in control, even if they are stressed at the beginning. But I really think that this system adds comfort not only for the medical team, but also for the patient. There are some small movies, so the patient understands when it's red, that's like cross light if you want. So red is not good, green is good, yellow is not good either. It's not replacing the CBCT. Alina underlined, and it's important to understand. You still rely on CBCT as for internal depicting the structures. Even if breast cancer, it's a good surrogate also for external surface, because you can do studies, and we are planning to do that, how different will be the CBCT to the only surface guidance, and try to identify patients which are not requiring CBCT just for decreasing the exposure dose. So this is good, beam on. This is not good, beam off. Can you turn it a little bit louder, please, maybe? This is one of our RTTs, patient daily work. We have, of course, video and audio monitoring of the patient. We are discussing with them, and we are trying to coach them even during the fraction, and of course expressing our gratitude if they are doing well, and not try to be too offensive if they are not managing to do it. So it's a relaxed atmosphere. Of course, it takes longer, but it doesn't matter. It's important, the safety and accuracy, to be sure that we are in the right place all over the session, the intrafraction motion. No problem. So the patient is getting into the right position. She see the green light above her head. It's keeping deep inspiration. The IMRT VMAT is running. You will see in a second after his head is moving how it's working. Now she released. That was the initial verification point to see if she really understood correctly. Of course, this is at the first fractions. Afterwards, they are knowing exactly what to do, and we are not prolonging the treatment, and we irradiate in windows of 20 seconds, 25. We have patients, and I will show you in a minute, patients that are able to keep more than 1 minute their breath. Of course, it's better if you have triple F, you can give quicker your treatment, especially for stereotactic radiotherapy. I think we can move on. For the first patients, of course, we did some comparative dosimetries, and also because we have the LINE-RT only on one LINAC, and if that one breaks, or it's in I don't know, setting of some displacement of old, let's say, or materials, which is happening everywhere all over the world, the maintenance. We can't treat the patients. Because we do not have the LINE-RT on the second LINAC, but we are contemplating that also. So we always try to have a free breathing dosimetry in order to be able to provide a treatment for the other machine, which are mirrored. So our two LINACs are exactly the same. And for those very rare occasions when we do not have the LINE-RT LINAC working, to able to put the patient on the other machine. And we saw a reduction of more than 50% in mean dose to the heart. So the red lines are for 8 patients as compared to free breathing, mean dose to the heart, V20 to the lung. It's the difference, it's less important, but it's still in the advantage of the deep inspiration, and also the 5 gray volume of the left lung receiving that dose. So again, precision, safety, comfort, which the price, which is, I don't know how relevant is. Of course, if you have 100 patients per LINAC to treat per day, it's important. But during COVID times, we were facing less number of patients per day, so we had all the time to do it right and without compromising the whole duration of the treatment, and without, let's say, missing any interval. So in conclusion, for breast, yes, deep inspiration is of many benefits, and I strongly encourage you to examine the opportunity to have one of this system, and it's already in the recommendation of a very renowned society of radiation, such as the German. The first author, I'm happy, it's a former of my student, which is now a radiation oncologist in Germany. So the use of deep inspiration breath hold as the best heart sparing technique. This is our clinic in Cluj. It's not so big and so nice as that in Bucharest, or even that of Timișoara and Alba, which are the newest one. But I have the pleasure to be part of a very strong team, and many thanks to the RTT's physicists, and of course to the doctors. Thank you. We'll have a session of Q&A just afterwards, but please feel free to address a burning question if you have, or if not, just note your questions and we'll be happy to try to answer the whole, let's say, stuff. If not, I will try to present you some other examples which are not maybe in your first radar scenario, lymphomas, and a couple of words about lung cancer. This presentation was meant to be given by my colleague, Dr. Renata Zahu, which unfortunately she couldn't be here today. We're gonna have these presentations after tomorrow also in Cluj, but I suppose that you will not attend, but she will have the opportunity to give her presentation. So also it's about, so we're gonna move from breast, we're still in the thorax level, and it's always about toxicity. But our former structure, which was target, at least the affected one, because if you have a left breast cancer, the contralateral is still organ at risk. But here in lymphomas and lung cancer, both breast are organ at risk, and the issue is secondary cancer. So because of exposure of this normal structure to develop some point later on, and this is measured around 8 to 10 years in median, secondary cancer. This is also true for lung cancer if you are dealing with lymphoma patients. And of course, the midline structure, esophagus, heart, again, heart, also with this type of diseases related to radiotherapy, spinal cord, and thyroid. Also secondary cancer, especially for lymphoma, because we are going up with our field sometimes much higher than for breast cancer. And this is particularly important for lymphoma patients because they are usually much younger than our breast counterparts. So they have a lifespan, and we are curing a lot of them, of course. So they have the opportunity to develop a second cancer. So even more, it's important to reduce as much as possible the dose to the breast, lung, and to the thyroid. Heart cancer, there is rarely described. We have some very rare patients, but this is not the issue. For the heart, it's the infarction, and we'll see some studies with valvular morbidity, and of course, heart insufficiency. So we are talking about radiation heart failure. We are talking about radiation pneumonitis, and it's much higher than for lung, for lymphoma patients. So it's around 10%, and it's even double the risk of developing a second cancer 25 years afterwards. For the lung cancer patients, the issue is the lung, the healthy lung, and of course they have a restriction of lung function also by the disease itself, I mean lung cancer, but they have chronic obstructive pulmonary disease, many of them related to tobacco or professional exposure. So there are some nomograms which are integrating two parameters, the mean lung dose and the volume receiving 5 grays, and the thresholds are 13.5 for the mean lung dose and 55% for the V5. And if you try to respect both of them and you achieve that, you have a very or a low risk of radiation pneumonitis, let's say below 10%. If you are not able to respect none, that goes to 50%. That's significant radiation pneumonitis. And this was the publication in the Advanced Radiation Oncology from the Andy Anderson team. And interestingly, in a multivariate analysis, the deep inspiration breath hold is the single factor which is relevant. bulky disease requiring salvage chemo or not, or even the dose of radiotherapy, didn't stand against deep inspiration in a multivariate analysis. And of course, you can measure that risk on such sort of a risk calculator like you are doing in many other diseases and come up with a probability of complication. When it comes to the heart, relevant on mean heart dose as in the breast, but also cardiac dose in homogeneity, you are in the mediastinum with your target. So where the heart is, so your target is just next to the heart, the mediastinum, in lymphoma patients. And of course, comorbidities such as diabetes, hypertension, and hypercholesterolemia. And if we look at the coronary artery disease, the risk is increased 2.5-fold if the mean heart dose is above 20 Gray. But not only that, also the valvular disease with the same cutoff. It goes to the sky quickly. And heart failure risk, of course, function of anthracycline. Also in lymphoma, we are giving a lot of adriamycin, which is also in breast cancer, sometimes replaced by epirubicin. So if you have drugs itself with heart toxicity, you will double at least the probability of heart morbidity on top of the radiation therapy, depending on the mean dose. Yes, you will say, but we are nowadays giving less dose to lymphoma patients and on smaller volumes. Agree. But even in that scenarios, we can try to do better because we have more conformal dose delivery, image-guided radiotherapy, motion management, and of course that functional imaging, fusion images that enable us to deliver the radiation where the residual disease is, or even completely omit radiotherapy, as recent trials have shown. If we speak about conformal dose delivery, we already know since 10 years already that IMRT reduces dose to organ at risk when compared to 3D conformal on lymphoma patients. This is a publication from 2012. And also about technique, this was described later on. It's called butterfly technique. Resembles all parallel opposed field, but with the advantage of beam modulation because it's IMRT VMAT, and avoid entry through lungs and breast. So actually you have only the window in oblique from 300 to 30 anterior and the corresponding posterior in the middle part. So small arcs, small excursions, not trespassing, if you want, the limit of the breast into the lateral. And a combination of non-coplanar planar technique, which was provided or advertised by the Torino University, as opposed to the MD Anderson which was more beams and with coplanar, let's say, disposition. So we examined, so we did some patients with both techniques, and we decided to use these butterfly techniques. These are the constraints for the dose. So breast mean dose less than 4 Grays, V5 less than 55%, and mean dose to the lung 10 Gray. Whereas the intended, so the target all the time would be to have a mean heart dose less than 5 Gray, kind of the same dose of breast. But again, here we are in the middle of the thorax with the target. But it was also accepted up to 15 Grays, but the final objective is this one. And I will try to show you in comparison how we moved from 3D to IMRT, from free breathing to deep inspiration, and later on from the full arc technique to the butterfly technique. So when it's about deep inspiration with IMRT, it's the best in mean heart dose as compared to deep inspiration, 3D conformal, free breathing IMRT, or 3D free breathing. And also for the lung, easy to keep in mind, better mean heart and lung dose. However, it's worse for breast mean dose if you compare it with 3D. It's not different in deep inspiration when it goes compared to free breathing, IMRT. So this issue has to be resolved, and I will show you how we can decrease by butterfly technique the dose, the mean breast dose, in order to be equivalent here. The mean thyroid dose, it's worse for deep inspiration IMRT, but it was not including in the planning. And the physicist in the room will say then it has zero value. If you not put constraints in your optimization plan, so this is irrelevant as per se graph. You need to include it in the constraints. But if you compile, if you put together all the good ones and the bad ones, including the breast cancer related to the higher dose to the breast, thyroid cancer related to the thyroid excess of dose, but also the good ones, the low heart dose, the low lung dose, on the global perspective, you are still better with IMRT deep inspiration breath hold. So these are single patients with their risk, which is cumulative, integrating all the risk of dying from heart morbidity, lung morbidity, radio-induced, or a second cancer. Let's move now for butterfly technique. So we are comparing deep inspiration and free breathing, and not anymore 3D conformal. We already said, okay, we are better with IMRT. We are trying to see if butterfly compared to full arc VMAT can decrease the dose to the heart, to the breast also, because we were expecting that it would be better for the mean lung dose and for V5 and also for the heart dose. So our deep inspiration butterfly VMAT technique, so you put together all your best that you have and you decrease the dose to the heart, and you see here we are below 5 gray, so we achieve the goal. And of course, even the high doses are even more reduced. And you see that the mean breast dose was not very different if it's a free breathing butterfly technique, VMAT, or a deep inspiration. But the butterfly is always better when you compare with full arc therapy with the same free breathing or deep inspiration counterparts. And this is also true for V5. So we understand that the butterfly technique adds value or decreases the dose to the breast, and the deep inspiration and IMRT was already proven to decrease the mean dose to the lung and to the heart. So with this combination, you have the best scenario, because reduced breast dose technique matters for these young patients. Our experience, so we had 18 thoracic lymphoma, and just to let's say be a bit provocative, I will show you a gastric lymphoma. So it's not only for thorax, it's also for abdomen, because you know there are some subtypes of lymphomas which are very indolent and where radiotherapy is curative, such as mild lymphoma and so forth, after, of course, absence of response to the Helicobacter eradication. So we implemented this deep inspiration aligner T technique. This is one of our patients, young, stage 2B classical Hodgkin lymphoma, nodular sclerosis. So just because he was B subtype and with a bulky mediastinum, it was just to be unfavorable. Stage 2 lymphoma with a very good response to the chemotherapy, so complete metabolic remission, Deauville 1. So we delivered him 30 gray because he was bulky initially, involved site radiotherapy, and we use that butterfly technique. And we were able to get the dose to the V5 lung, not 55% as the guidelines, the Torino, 36%, the V20, well below the intended threshold, and the mean lung dose. However, for the heart, we were not able to get it lower than 5 gray as a mean heart dose. So, but it was much better than the full arc VMAT. So this patient, as I told you previously, was able to keep his breath hold for more than 1 minute. So the treatment was quite fast, even if you have non-coplanar arcs. Of course, with the CBCT verification, this is our gastric lymphoma patient. So in deep inspiration, you see the diaphragm push downwards, the stomach, the heart, it's getting to the midline, and you have quite a difference in terms of PTV overlapping as opposed to free breathing PTV depicted on the right side. We were having only one patient, but this paper, if you want to see from MD Anderson, is looking at the dosimetry and advantages for 10 patients. These are our patients with a mean heart dose 3.5 gray and mean lung dose 4 grays, which was good. When it comes to lung cancer, and I will end up with that in a couple of slides, we identified 2 applications, at least for this device. So deep inspiration breath hold technique, because this is the topic that I'm speaking. I'm not speaking about stereotactic radiotherapy. Probably we'll have some other intervenants for that. So deep inspiration verification with surface-guided radiotherapy for non-stereotactic treatment, and a bit about setup assistance for stereotactic for a lung, whether metastatic or primary stereotactic radiotherapy, but not replacing the CBCT, which still is the gold standard. This trial looked, okay, for lung cancer patients, how reproducible might be this deep inspiration breath hold in the setting of keeping at least 3 intervals consecutive of 20 seconds deep inspiration. Because we understand easily that those patients are having a obstructive pulmonary disease, and they are not able to keep the respiration for longer periods or for such long periods as lymphoma young patients without any lung problems. So this was a feasibility study. How real life is going to show among patients which were including 88, we end up with the 62 patients which were compliant for definitive radiation therapy for 6 weeks radiation therapy. This is not stereotactic radiotherapy. Those patients were excluded. And actually, the conclusion was that more than 2/3 of them are able to keep deep inspiration the whole length of the treatment. So this is a real-world significant data. Is feasible in your daily practice, if you want. We have only 2 patients of that. We are doing 4DCT for every cancer patient, but the motion management, it's under the concept of ITV, and only if it's much bigger than the threshold that we agreed upon, we will try to do in deep inspiration, but that's also subject for our PhDs, for our research crew. So the question, when you are leaving the patient breathing freely and you are doing SGRT, of course, the time of treatment is much longer than 2 gray per fraction. We do not do a comparison of triple F without triple F. Let's say if you don't have triple F, the difference is quite big if you want to deliver doses of 18 grays per fraction multiplied 3 for, let's say, situated primary early lung cancer as a definitive treatment. So the intrafraction from the first second to the last second of delivery of 80 gray will be long. And you need to have a reassurance additional to the CBCT that you are taking just before pushing the button for starting radiotherapy and at the end of the radiotherapy. What's happening in between? Of course, you will say you can do another one in the middle. Okay, those are snapshots. How relevant are for the whole duration of treatment? And sometimes you are frightened when you see a moving film of your target. Of course, you integrated that in your ITV and so forth. So you did something in order to be sure that your PTV gets the dose that you are intended. But you would like to know or get even closer to the absolute truth, what's happening in between. And of course, from a clinical point of view, because by the end of the day, doctors will say, okay, how relevant is that 1, 2, 3, 4 millimeters for toxicity or for target coverage? Even if your physicist is showing you that it's not okay, you are doing a dynamic plan, adaptive planning, and you are seeing that on paper it looks still okay. That's for sure, and this was also underlined by a previous speaker. You are able, by deep inspiration breath hold, to reduce PTV because you will have the motion in a lesser degree, so you are able, or you are comfortable to add smaller margin to the CTV as if you are leaving the patient breathing in free. This is our workflow, of course. The principle is the same. So you have as objective that your aim is to have all green here as long as possible to be able to deliver stereotactic lung radiotherapy. And this is my conclusion. So yes, you can reduce your target volumes. Of course, by that you will reduce your organ at risk exposure on top of the really technique radiotherapy related, I mean IMRT versus other techniques, and especially important for fit young lymphoma patients. We are looking forward to see our data on lung cancer patients because there are, this, from my knowledge, scarce literature on that topic. So I should wrote in red because the red is a good color in Align RT. Align RT system, excellent tool for implementing deep inspiration, and I thank you for attention.
Thank you,
This
Gabi.
is open for the questions.
Yeah, it's open for the questions. Any questions for Gabi for the two presentations? Yes.
Thank you very much. I have two questions and a comment. First question is, do you expand your PTV margins when you're doing a breath hold therapy, although you're using the SGRT?
If I'm doing stereotactic or for a regular
Whatever,
base?
it doesn't matter.
So we have, for example, for breast cancer, we reduced from 7 millimeter in free breathing to 5 millimeter.
You have reduced, even
Yes.
reduced. Okay. And I have a comment and I would like to ask your opinion. You're always implementing, when doing a breath hold, you're always mentioning about deep inspiration breath hold. But we have just figured out that for some patients, deep inspiration is really very difficult and the reproducibility is not as good as the others. So if your intention is just to freeze the tumor, then you don't need to increase the lung volume because you need to decrease the V5s and V20s. It could be more comfortable to do the breath hold in the end experience because it is more reproducible. That's what we recommend to do, especially when you're treating small volumes like lung SGRTs. Do you have any comments about it?
You're absolutely true, and we are doing that for stereotactic to the liver and expiratory phase. That's, let's say, the position where the diaphragm it's moving the least, and the patient are able, what's exactly what you said, that they are able to keep that. I think even mid-inspiration might be a problem if the patient is keeping the breath hold at that position, but you are completely right. Probably the coaching phase should examine the patient's ability of and do not deny deep inspiration just because he's not or she's not able to hold more than 20 seconds. You are completely right, yes.
Just a comment to your question about the PTV margins. If you look at that one, the beacon, and we decrease it at 3 millimeter margin, but it depends on the accuracy of your imaging. So I think that it doesn't really depend on if you use deep inspiration and expiration. The margin from the ITV to the PTV will depend on the accuracy of the imaging that you have on board.
I want to. No. We have been discussing this with our physicists for a period of time. With the ITV method, you have a margin and it's ITV. But with breath hold, you don't have a margin. And the only margin that you have is PTV. So our physicist recommends us to expand the PTV margin a little bit, just to be sure, right?
So usually we looked also at the accuracy of the breath hold. And in fact, yes, you have the residual motion in the breath hold window. You can verify it by using fluoro and then still keep like for deep inspiration is to use 5 millimeter just to have 2 millimeter margin, but we always check that the tumor remains in the gating window. Let's say gating window. We're using fluoro.
Okay, so it's a window.
It
the
is.
window, it moves as well, right? Yeah.
But it depends. The PTV margin depends, in my opinion, on the accuracy of the imaging and positioning operators.
About the point you raised regarding the lungs, it's true that you have a bigger volume when you are inflating them, but if I was showing you some tables, the absolute volume in cc, it's bigger if you want, but the percentage is lower because it's a percentage applied to a bigger volume, so your V20 in percentage will be less. In absolute cc, cube centimeters, sometimes is bigger. But even there, you decrease by deep. Yeah.
So if you want to get an advantage on the lung dosimetry, obviously doing a deep inspirium or inspirium breath hold is advantageous.
Okay.
Like if you're treating large volumes, that's what we're doing in like a stage 3 lung cancer treatments. But for very small targets, if you want to freeze the tuber, it's better to do that and experience because it's more reproducible and it quickens the treatment time for the patient.
Correct.
You can use gating.
Well, I don't like gating.
You can use gating if you can verify it.
Okay, thank you.
Any questions, please?
Any other questions from the audience?
It looks complicated. It's not. It's not. Really. You will see in the afternoon. It's very friendly.
Okay, so we have a break now.
No, there is a questions over there,
yeah,
please.
Do you have any criteria to, or what kind of patient do you have candidate for the SGRT in your department? So are you treat all the patients with SGRT or do you have any criteria?
So initially, we were putting first the compliance, the ability to stand, to keep the breath hold for at least 20 seconds and to be younger than 50. Of course, left breast didn't start from the start point. To be younger than 50 and receiving systemic treatment with cardiac toxicity, whatever HER2 therapy or anthracycline and so forth. But then we see that it's so friendly and we were able to speed up the process because initially we were not sure that we are doing the right thing as any new device. And the slot times for the patient were even double that the regular ones. And this was not productive. So we are, let's say, a private hospital, but of course everything is free of charge because it's reimbursed by the state. But at the end of the day, we were prolonging the treatment and on one machine. As I said, it's only on one machine. So we were having, I don't know, 50 patients on the LINAC 1 and 75 on the other. And of course, the RTTs were not happy. Why we have to work more than the others in number of patients and so forth. But this is not the point. So initially, we were putting some, let's say, strict criteria. And we saw that there are, I don't know, per day we had maybe 5, 10 patients with fulfilling the criteria. And then when we saw that we are faster and we like it, we, let's say, relaxed the constraints, and we are now doing for every left breast cancer patient and for some of right left patients. I don't know what your policy or opinion.
Yeah, like
I'm sorry. Yeah, we're treating all of our left breasts with deep inspiration if obviously the patient can do that. But we have the Radixact system as well, and anything which includes the lymph nodes, we do IMRT because of the dose homogeneity. So we use the advantage of the homogeneity, but only left breasts with a deep inspiration breath hold.
Mm-hmm.
we
Thank
use
you.
it for all the breasts.
But you have on all machines your eyeliner.
We have, yeah, we have align RT on both machines, not on the CT.
Okay.
And I like no, even
And in Anadolu, you have on 2 machines, 3 machines.
Yeah.
We have 4. I will
Yeah.
give information.
A line, okay.
Only one. So because we have only one LINAC, very LINAC, and that is with the align, with the vision RT. We have a cyber knife and the tomotherapy. So.
all right,
I
so
believe.
so we are going on a break now. We reconvene at 2:15 sharp, please.
Thank you for activating the atmosphere.
Sorry about the pronunciation. Who will present the clinical application of SGRT, the indications and workflow.
Hi, hello everyone. Thank you for the invitation. So for the following 20 minutes, I would like to give some feedback about how we're using the system in our hospital. So first, I would like to make a couple of comments about our team, our hospital, and the treatment platforms that we have. The definition of SGRT from our perspective and why we think that it might be a little more advantageous than the other systems, and make comments about a little bit of evidence, and then the indications and the workflow as case examples. And after that, if you have any questions, I'm obviously happy to answer them. So we are a very small standalone private hospital in the border of Istanbul and Kocaeli, one of two big cities in Turkey. We are 4 radiation oncologists, 4 physicists. We have 2 dosimetrists, 10 technologists, and 3 dedicated nurses in our radiation oncology department. We treat all types of radiation therapies, but we don't have any brachytherapy. We're one of the very well-known clinics for radiosurgery, so we are a referral site for most of the national hospitals, but also we treat a lot of international hospitals as well. So roughly around 50% of our whole patients are being treated with radiosurgery. That is the reason why we have a lot of radiosurgery systems. And we roughly treat about 1,000 patients per year. Yeah, 1,000 patients per year. So as I said, we are a standalone private hospital, and this hospital was established in 2005. From the moment it was established, we are affiliated to Johns Hopkins International, and we have very good collaborations with them. Obviously, we treat a lot of different patient groups, but mainly the hospital is treating oncology patients. So we majorly, like 80% of the patients applying to our hospital are being diagnosed with cancer. We have a very strong international department and treat a lot of patients in this geography. We are a member of ESMO, a member of EORTC, and member of OECI. OECI is a system of an accreditation company system mainly in European hospitals. So we have to, in order to be accredited to that system, and it's the only hospital, as far as I know, in Turkey, we have a lot of dedicated tumor boards, and every patient that has the potential of being diagnosed as cancer or as being diagnosed with cancer has to be discussed in the multidisciplinary dedicated tumor boards before proceeding to any of the treatments. This team, met with the hospital starting from May 2017. So we're working in this hospital for roughly 5 years, but the team was working together before applying to this hospital in another hospital. So the team knows each other for more than 10 years, which is one of the most important things, because radiation therapy is a teamwork. And when you know each other, you spend most of your dedication to something else, which is radiotherapy. Those are the treatment platforms that we have. We have a Varian Edge system with SGRT from VisionRT. We have a HyperArc software. This is a software for intracranial SRS applications. Majorly, it has been performed for doing multiple intracranial metastasis. But very recently, we have been using this with high-grade and low-grade malignant gliomas as well, for low-grade and high-grade gliomas as well, for conventional fractionations, because it decreases the total treatment time, and it protects the remnant brain, which is a very important thing for large brain radiations. We have an ICBCT, which is a a reconstructed CBCT image with the AI, you get brighter images. Especially it is important when you're treating intra-abdominal targets. And we have the HD MLC, obviously. That is the reason why they call it the variant edge. We have a CyberKnife. The first time we had purchased it was M6, but now it has been upgraded to S7. We have the MLC and IDMS with the VOLO calculation system. And when you have the VOLO, they call it S7. The software is called the Precision, the treatment planning software. And this is the server, and it has been connected with the Radixact because there are two Accuray products. Now we have a single server system for these two different treatment platforms and a same treatment planning not the algorithm, but the treatment planning software, which is called Precision. We have the Precise Art and RTX, which is a dedicated artificial intelligence system for offline adaptive radiotherapy. Very recently, I guess it was 2 years ago, we have purchased the intraoperative radiotherapy from Zoft Accent. It has been defined as electronic brachytherapy. We majorly use it for breast cancer intraoperative radiotherapy applications. So a lot has been improved in radiation treatments since the first time I have started my residency. It was 23 years ago. Now we're treating higher doses and smaller targets. So we are giving narrower margins to predefined anatomies. So we're implementing a lot of nice imaging into our treatments plannings, but also those images has to be in the treatment room as well. And there is motion. Obviously, we didn't know about motion in the past, but there is motion, and we have to take care of that if we are doing this type of treatments. But there are two types of motions. Some of them are predictable, the ones that we're concentrating more, like the respiration, but there are some unpredictable motions as well. For example, the gas flow when you're treating prostate radiation, prostate SGRT. So we have to have some other technologies for unpredictable motion, which is beyond my talk this time. When you're doing very advanced radiation therapies, you need to have good IGRT systems in your treatment room, but also you need to have good localization technologies as well. In the past, we were using marker-based systems. Marker-based systems are, they passively track a reflective marker with an imaging system operating the infrared spectrum, and it actively tracks an RF beacon using a set of RF receivers. But it's a block, it's a marker, it's just a small area, it's a small part of the body that you're tracking, that you're seeing. But the surface-based systems are more advanced because they have advances in computing power and imaging technology, and it allows the mapping of many arbitrary points, which is more precise and more reliable on the patient, while simultaneously tracking their position over time, which is another important thing. I mean, you're looking at a larger area and you're doing over time. These points comprise a 3D surface, and it can be considered an extension of a marker-based approach. So literally it means putting a lot of markers within the body, which defines a surface. And it corresponds improvements in the ability to relate a patient's current position and posture to a reference. So this is a system. It's video-based 3D surface imaging system. It is used to detect and reconstruct the skin surface of a patient in 3D before and during radiotherapy treatment like this. It's non-invasive, and it's real-time, and it's non-ionizing, which are more advantages. Those are some of the advantages why we think that this system is better approach than marker-based systems, because it enables reduction of initial setup variability, and it decreases the setup time. You think that it might increase the setup time, but on the contrary, it's more practical because you don't have to go inside the machine and reposition the patient, and you can do everything, the initial positioning, with more accuracy within the treatment room. Provides verification of immobilization continuously during the treatment. And you can even do it with non-coplanar Linac gantry angles, which we use a lot, especially when you're doing intracranial SRS or large field lung cancer treatments. Non-coplanar beams increases the dosimetric advantage, especially for the lung and the heart. And marker-based systems cannot do a verification during the treatment when you're using non-coplanar gantry angles, but this system can do. And it provides dynamic surface information for use in gated and breath hold treatment techniques if you want to. And we want it and we use it. It permits reductions in the margin. So when you decrease the margins, you can escalate the dose, and you can definitely decrease the side effects, which is a major issue, for example, with intracranial SRS. Now, for intracranial metastasis, our PTV margins are 0. And if you do not treat the right area, obviously the local controls will be very, very low. The ability to use immobilization techniques that confer greater comfort to patients, reduction in imaging dose through reduced radiographic localization requirements, and it improves the speed, the efficacy, and the safety of clinical workflows. So, why SGRT? We use SGRT for first, initially, patient positioning. We decrease the positioning time, the setup time, and we decrease the imaging dose, which is an advantage. We use the technology after the positioning in real-time monitoring during the treatment. There is additional level of safety, and there is online surface deviation, which you see throughout the treatment. And you can do gated RT delivery, either with DIBH and you can see the intra-DIBH stability, which I was mentioning in the previous discussions. So even when you do a DIBH, there's always a variability, and without having a surface guided radiotherapy technique, you can never understand the DIBH, intra-DIBH stability. And when the system, when you're doing this real-time monitoring during treatment, when there is a motion, the system automatically turns the beam off, which is another advantage. So you're not only looking at the screen itself, the system can understand that there is a deviation in the motion, and the beam turns off automatically. So we get the in-room online information of the complete surface and position of the patient. We use it for superficial tumors like breast cancer, where surface deviations can act as a surrogate for tumor motion. We can do more accurate positioning compared to 3-point lasers, and we can reduce the number of daily imaging if you're a very busy clinic. For deeper located tumors like, for example, lung SGRT, when there is no direct correlation between surface deviations and tumor movement, obviously we always have a CBCT, daily imaging, which was mentioned before, but SGRT can reduce the time required for image registration, and you can prevent the need for multiple imaging. For example, when you do a CBCT, you correct the couch position in 6th dimension, and we always used to do a re-CBCT to proceed with treatment after this SGRT. We don't do that anymore. There is evidence. I mean, there is evidence. There is evidence of using SGRT in a very efficient way in multiple indications, in multiple techniques. For example, for DIBH systems, for prostate cancer patients, for head and neck cancer patients, for optical surface monitoring. So there are different indications for that. But I don't want to go into details of those evidences, but I want to give a little bit more information of this evidence that was published in 2017, as far as I remember. This is a review of in-room IGRT methods before and during lung SGRT. And when you compare different techniques, the SGRT systems was defined as more advantageous in detected unexpected patient motion, for example, cough. And breath hold treatments can be done more efficiently if you're using an SGRT. So there is evidence that SGRT is more efficacious than other like marker-based techniques. So this is the basic components of the system. You have a main workstation and a PC at treatment console. You have the same workstation in the treatment room, and together with camera pods and calibration plates in the treatment room. We have, I'm traveling here with our physicists, so if you have more technical questions that I cannot reply, you can ask the questions to him as well. So this is what we have in the room. The patient lays down. This is our room. There are 3 pods. The cameras are called pods. In the pod, there are LEDs, the projection, and the image sensor. So these pods are located in the ceiling, and we have our RPM system as well, where the variant provides. But also, addition to that, we have those pod systems. Each pod contains 2 camera sensors. You see this and this, and a projector enabling real-time 3D surface reconstruction. The live surface is registered to a reference surface generating 6D shift information. This reference is coming from the planning CT. I will show it to you. The 3 pods project a speckled red light pattern onto patient's surface. The stereo camera pods image pattern in 3D, and software reconstructs the full surface. And then you have the information of the whole surface, and this surface that you reconstruct is matched in real time to the reference image. So the reference image that we use is usually from CT, but if you don't have it, you can create your reference image the first time the patient enters to the room in the treatment room as well. This is a workflow. You have to create a region of interest. Although the entire reference surface is displayed, it's only the selected ROI that the system uses for fusion, and it is you who create the ROIs according to the area where you're treating. For example, if you're treating a large lung cancer, the ROI that we create is like this, but if you're treating breast, we usually select the breast as the ROI. I will show you examples. In some cases, 2 different ROIs can be used for the same patient as well, but it's a little more tricky and complicated, so we prefer not to use, but Nadir can give some more information where we use 2 different ROIs. This is the workflow. So this is the planning. The Eclipse, when you're exporting the image, you're always exporting it to the Vision RT system as well for the so when you're creating your treatment planning CTs, you always have to have the body as a structure. Otherwise, you cannot create a surface. And obviously, you have to export the plan because of the ISO center. And then this reference surface is created, and you create an ROI for the fusion with this surface that is creating in the planning CT. And this is for the setup. We always use the postural video for setup, and like it's really very easy to set up the patients, especially when there is arm motions, because you always create the positions before setting up the patient, and the treatment time that you spend for setup definitely decreases when you use the system. And then you have this camera in the treatment room. So we do the setup looking at those 6 informations in the treatment room when you're doing the setup. You do the setup and you leave the room, you scan the patient, get the cone beam CT, and you do the couch corrections, and then you start it. When you're starting, you have the same camera in the treatment console as well, and it's automatically looking if there is a motion. This is for free breathing and also for breath holds. And whenever those 6 factors that you have created before is out of the range that you have initially created, the beam automatically stops. So this is the workflow, for example, for lung SBRT. Before Vision RT, we were doing lung SBRT like this. We were positioning patient with lasers. We were having a 2D, 3D registration first with KV, and then switching in the first CBCT. The shifts were applied according to the CBCT, the 6 direction couch corrections. And we were having a re-CBCT before proceeding with treatment. During the treatment, we were controlling the patient with RPM only. And then after the treatment, we were having a post-CBCT. After the Vision RT system, I think we were using it for like 3.5 years. Now we are having the postural video for setup. So we're not positioning the patient with the lasers anymore. We're not using tattoos, markers. I think not having tattoos on patient is a thing because it might remind the old bad memories for the patient. We're not doing a 2D, 3D registration anymore. And we're not doing a post-CBCT anymore. Nowadays, we are a little bit more crowded, so we're not having this second CBCT anymore as well. So those are the cases that we illustrate the clinical utility of Vision RT system in our hospital. We are doing SRS SBRT. We're treating SRS SBRTs for lung, some of the brain, adrenal, spine, liver, prostate, and pancreatic tumors. And we use the system, the surface-guided radiotherapy in all of those. And for conventional treatment for left breast, thoracic malignancies, and extremity sarcomas. So far, we only have one LINAC, so we have treated more than 1,000 patients so far in 3 years with one LINAC. I think it's a nice number for a standalone private hospital compared with big universities. So this is one of the workflows. This was discussed in a very detailed way. I don't want to go into detail, but as it has been stated before, when you do deep inspiration breath hold, the probability of you saving the heart, which is a major area of toxicity in the long term for long-term survivals, we always have to detect if the patient is really doing their deep inspiration breath hold, because having a very good treatment planning with deep inspiration breath hold in the treatment planning console is fine, but as long as you cannot apply it during the treatments, you cannot spare the heart. So the best way to understand the deep inspiration breath hold is when you have to look at the whole surface. And there is a variability in deep inspiration breath hold as well. How do we manage that? The system has its camera, but we also have the RGSC camera as well, coming from the RPM system that Varian provides. You can use both because the patient is in the treatment right now. They're looking at the window that you have created. And when the breath hold is within the window, everything seems fine. But when the breath hold is out of the window that we have created before, the beam turns off automatically. As I said, this is the RGSC camera, but Vision RT has their own camera as well. In the past, we didn't have this camera, so we were roughly using this camera more. But now we have the Vision RT camera as well, and it's really very user-friendly. So this is the ROI that we create for left breast cancers. We always include a little bit of a lateral aspect because when the gantry is turning, when one of the pods is blocked, then you can still use the other pods if you create a little bit more lateral aspect of the breast tissue. We use it both for free breathing and DIBH. We use it for initial setup and throughout the whole treatment course. We use it for the brain SRS. Obviously, we have a CyberKnife. I'm sure that you have in your mind, why do you use the Linux system for brain SRS? In Turkey, reimbursement issues are a little bit more complicated. Some of the brain metastases we cannot treat with CyberKnife, or we can obviously, but it cannot be reimbursed. So We treat it in the Linux system. We have to have an open mask because the system only looks at the surface. The lateral surface has to be open, and there has to be at least 2 centimeters space from the eyebrow, and there has to be a rigid chin positioning. We use the HyperArc treatment. It's, as I said, it's a software for treating intracranial metastasis. And during the treatment, this is the ROI that we created. You can see that the motion is really fairly low. So as a summary, I think more precise radiation therapy allows better local control. I think there is not any objection to this comment. And we can do that so we can treat the patients better with less toxicity. But obviously the good plans are essential. Good plans are essential for this. And also the IGRT is essential. As long as you have good plans, it's fine. But if you cannot apply it in the treatment room, it's not going to work. So setup is important. In-room imaging is important. Motion is important. Sometimes you need to do gating. And SGRT provides more confidence in most of so many subtitles that I have mentioned in this slide. I thank you for your attention.
Very nice presentation indeed. Any questions from the audience, please? Sure.
So my question is, there's a big buzz about treating ventricular tachycardia with as ablative therapy. Have you done it? And
No.
do you think about the role of LNRT into that type of treatments? You know, beyond cancer, to be honest.
Well, you know, you're asking this question to a CyberKnife user directly, so I'm not so sure about it. Yeah, we plan to open a program for cardiac SGRT. Well, it's a challenge because you have to include the cardiologists, you know, to the field. And first of all, you have to persuade them that this works. I know that from my American colleagues that it took a while for them to persuade the cardiologists. So we're in that period right now. We obviously plan to do that. Well, the only way that you can do it with the CyberKnife system is you have to place the fiducials. But if you cannot, yeah, it might work. But, you know, cardiac motion is a little bit more complicated than the respiration motion. It's predictable, but you have a 4D CT dedicated to cardiac motion. So it's a little bit different software than the respiration 4D systems. So I would definitely use some sort of a tracking, which would come from inside. I would feel more confident as a radiation oncologist, but there are a lot of different it might be there are a lot of aspects replying this question. I don't know what others think.
We have another question there.
All right.
Okay, thank you very much. Excellent talk.
Thank you.
Nice to meet you again. So, do you think that SGRT could help for total marrow irradiation, total body?
Well,
There is some
so-
place to think
yeah.
about.
Well, so we have the edge. So we always have to treat small fields, and the system that we use for total body radiation is our Radixact. So I don't have any experience. Nadia, do you think that SGRT can work for total body radiations for like if you have a true beam or what?
Yeah, it could be maybe because, you know, in TBI, total body radiation, we are doing a lot of imaging, you know, especially for the tomo. So we are dividing to, you know, two or three imaging from the upper side of the patient, and, you know, lower side of the patient, we need to get another imaging. So especially for the extremities, surface tracking is, SGRT is really work in, especially for the extremities to immobilize it. And another thing for the total body, I think the Vision RT people are here. I saw that in the last Astro, also they are probably within 2 or 3 years, they will do some, you know, dose measurement, which means that, you know, one of the big problem in the TBI. So we, you know, we will get some information from the surface dose with the SGRT, with the Vision RT, which means that you don't need to get another measurement, or you don't need to put, you know, TLD or some other extra, you know, measurement you don't need maybe in the future. So for now, I think still it will work, of course, if you do if you create a good ROI, we don't have any experience at the moment because we are using a Redstack system for TBI. If you are creating a good ROI, of course, I think it could be work.
Maybe that might be the area where you might have more than one ROI,
Yeah.
right?
Yeah. This is another option. Yeah.
Yeah, I think it was a very good question. Thanks.
In addition to TBI, there are a lot of centers that are using it for craniospinal irradiation as well. So not necessarily total body irradiation, but craniospinal, where you have multiple isocenters. They are, like you mentioned, different regions of interest for the different isocenters. So for the cranial component, the spinal component right down to the pelvic region. So I have been involved with sites for craniospinal irradiation, pediatric and sort of adolescent as well.
Yeah, as we have the edge, we don't have that sort of information from the edge.
Have time for one more question? Any other question?
I was just thinking about the indications for large field irradiation. And I remember some of our patients, we had very few with total skin irradiation. And I think that's even better for surface guided. So there are lymphomas with skin tropism, and we were having awful times with our physicists to cover whole skin, especially to avoid underdosage or overdosage in flexion areas and so forth. And probably it would be also interesting to see the skin dose with the image surface guided as compared to in vivo dosimetry, to put on breast T4Bs, because sometimes we are using that in pre-op. I don't know if you in pre-op irradiation, and try to see with some TLDs what's the real let's say connection or superposing the measurements with the image. That so there are a lot of things that we can do.
Thank you. Thank you very much.
Thank you very much.
So we have a slight switch in the presentation. So the next topic will be SGRT, the paradigm shift with Align RT. Wesley Naido. Yeah.
Good afternoon once more. You hear from me again. So I'm going to cover a little about the use of SGRT and more or less this paradigm shift from how we have been doing things traditionally to surface-guided based radiotherapy treatments. The Vision RT portfolio covers a wide range of products from expanding throughout the entire patient journey. So this is from the point of check-in all the way through to treatment delivery. The products that I'm going to focus on in this discussion is Align RT, which is our core product. The in-wall component, now that we are transitioning from conventional CM-Linux to bore-based radiotherapy solutions, as well as a SIM-RT component, which is used during the pre-treatment period. So what can SGRT do? And you've heard from the previous speakers, there is an increasing demand for radiotherapy treatment. So we want to deliver treatment that is accurate, that is efficient for patient positioning. The additional component is having the information about patient motion. So patients move and we want to be able to detect that motion. So there's the intrafraction component. The way in which radiotherapy has been delivered, we know that there's usually the tattoos, which we rely on, or some form of skin marking to initially align our patients. Generally, there's also very invasive or enclosed fixation or immobilization devices, which are not necessarily comfortable for the patient. In addition, when we are looking at the imaging modalities available, we have the onboard imaging, KV, CBCT, also exact tract imaging, which is used in SRS cases majority of the time. There's no real-time imaging or feedback from these technologies. There's also the additional radiation exposure for the patient. And then again, with some solutions that are available for respiratory motion management, Again, not as comfortable for the patient. They require some sort of snorkel, some sort of a spirometer, which the patient has to have within their mouth, a nose clamp, and sometimes a goggle or some sort of visual aid as well. So these are challenges that we see with the way in which we do things presently. But what does SGRT offer? So SGRT offers this paradigm shift to enable us to deliver more accurate and more comfortable patient experience. So what can SGRT be used for? And you've seen in the different presentations here that it covers a wide variety of applications. It can be used for all anatomical sites and all treatment indications. In addition to the clinical use, it is supported by peer-reviewed papers for multiple indications. So again, this has been touched on, so it might be a bit of repetition, but how does the SGRT system or technology work? Here we have these 3 ceiling-mounted cameras, and currently they project this red infrared, near-infrared light with a pseudo-random speckle pattern onto the patient's surface. The image sensors of the cameras are using that information to generate a 3D surface, and that's matched in relation to the DICOM to enable 2 important components. One being the initial patient setup, and here we can get an accurate patient positioning in all 6 degrees of freedom. So prior to acquiring your CBCT, it is possible to correct patient rotations as well as translations. We also have the tool for postural video setup that allows you to position the arm, the chin, so you have a good postural as well as isocentric position. And the second component, which has been touched on today, is the intrafraction motion. So we have this real-time feedback throughout the entire treatment delivery with the option of the automatic beam hold. Very high-level overview of the treatment workflow. The pre-treatment process and the planning process remains fundamentally unchanged. We only need to define this region of interest once before the treatment delivery, and then Align-RT is used during the setup and monitoring process. So what does this mean for the patient, and what does this mean for you as a radiation therapist? We can do a much more faster initial patient alignment. So we get a good postural and isocentric setup pre-imaging. Depending on the clinical indication or the anatomical site, SGRT can either complement or it can reduce the frequency of the radiographic imaging. We did touch on some of the benefits here is we don't need to rely on the tattoos or the skin markings for patient positioning. We can use purely the reference surface within the Align-RT system. And this implies that the patient doesn't need any skin markings. We don't rely on those tattoos. We can just focus on the SGRT system during the initial alignment. In terms of immobilization, it removes the need for very enclosed, fixated, uncomfortable immobilization devices. A lot of centers have moved away from thermoplastic body casts, as well as you've seen the earlier example for SRS cases, you have the opening in the mask, so patients are less claustrophobic. It's a lot more comfortable experience. We have, like we mentioned, the real-time monitoring, but in addition, not just at couch zero, but even at the non-coplanar fields where X-ray imaging is not possible, you do have the real-time feedback from the Align-RT system. We can achieve a submillimetric accuracy here of less than 0.3 millimeters and 0.2 degrees, even at non-coplanar fields. The beam control, so based on these predefined thresholds that you see up on your screen, when the patient exceeds this, the beam is held automatically and based on all 6 degrees of freedom. So it's not just gating on or gating the beam on one specific parameter, it's based on all 6 degrees of freedom. And the response time of the system is near real time. The frame rate, the processing frame rate is extremely high. So at the moment the patient moves outside of tolerance, the beam is held instantaneously. So this tool that we've been mentioning and you've heard before is postural video. So how do we use this during the patient alignment? Here you can see that you have the purple outlines, which are automatically generated from your planning CT. So here you have real-time high resolution feedback from all three cameras. So the therapist is looking at the screen with the real-time video feed, and it's easily to identify how do you need to position the patient arm, how do you need to position the chin to ensure that you have a good alignment pre-imaging or pre-treatment delivery. So notice on the screen when the patient moves their arm, or if it's not accurately aligned, it's easy to identify which direction, which orientation to correct your patient position. The benefit of using the surface here is also if there are any changes in relation to the reference, so either from your DICOM or from a surface that you captured with the Align-RT system, any surface change, any contour change is being able to be quantified or identified with the SGRT system. So typically with breast cancer patients, if you have a seroma, if you have a decrease or resolution of that seroma, the Align-RT system using the surface deformation will be able to quantify, so you can identify where exactly and what is that percentage change within that region of interest or across the surface of the patient. So this is displayed here quite easily. It's quite intuitive to understand. You get some quantitative values, but you also have this color wash display. And that will give you or guide your clinical decision. Can you continue with the plan? How does it correspond to your internal imaging? Do you need to adjust anything for the duration of the treatment? So here, this is just going to give you some additional information to decide on the way forward. Prof. Kocher has mentioned this study earlier regarding the use of Align-RT in deep inspiration breath hold treatments and the verification on SPECT imaging that there was 0% cardiac perfusion defects in these left breast cancer patients. So one of the clinical indications here is the use of SGRT in breast treatments, specifically left breast cancer treatments. There is published evidence here supporting the use of Align-RT in deep inspiration breath hold. For the patient, it's quite easy to follow. For the staff, the software is quite user-friendly and intuitive. And in addition, we don't need to have any fiducials, any blocks, any markers on the patient's surface itself. So again, we're using the full contour of the patient's surface with a defined region of interest. Again, the advantage of using Align-RT for these patients is you have the possibility of not just looking at the amplitude or looking at the vertical change. Align-RT is monitoring your patient in all 6 degrees of freedom. And typically breast cancer patients, once they start to tire during treatment, they tend to drop the arm. Some patients don't necessarily breathe in to inflate the lung. Sometimes they breathe from the belly. Sometimes they arch their back to achieve that position. And with the use of Align-RT, we can ensure that the patient has a reproducible breath with each breath hold and in all 6 degrees of freedom. An additional clinical indication, which is, of course, the use in SRS, and Prof. Khaled has just presented this in the previous presentation. Again, in these techniques where we need to have really high dose conformity, usually this is achieved by the use of non-coplanar fields, just to ensure that we can deliver maximum dose to the target and we can avoid those dose to the surrounding organs at risk and the long-term implications of that. So at non-coplanar fields, the most challenging or the limitation here is not being able to use traditional onboard imaging or X-ray imaging because you have the risk of the collision depending at the couch angle that you're at. So the use, or with these more complex techniques, especially where we have multiple metastases with a single isocenter, we want to ensure that firstly, we have an accurate initial alignment because any small discrepancies with rotations are magnified for those lesions further away from the isocenter. So we want to ensure that the initial correction in all 6 degrees of freedom is as precise as possible. And then we have the advantage of monitoring the patient in real time throughout that delivery process. The treatment times are generally longer, so patients typically move, but we can detect that motion and ensure that we constrain that motion to within 1 millimeter and 1 degree. How do we achieve these high levels of accuracy with a surface-guided system? We perform the standard calibration using the plate that you see here, but in addition, we perform an advanced calibration or camera optimization at the time of installation. Together with a cube calibration, and this is specific for your high conformity treatments such as SRS and your non-coplanar SGRT treatments. So together with these calibrations and these radiographic verification, we can achieve an accuracy that I mentioned of 0.3 millimeters and 0.2 degrees at non-coplanar fields. So this is true for even the most challenging gantry positions and couch angles. So you can see that we can maintain a really high level of accuracy in these treatment techniques. So why do we need to ensure an accurate calibration with the Align-RT system initially for these techniques is because when we move away from the zero position, as we move, if there's any misalignment between the radiographic and the SGRT system, this effect can be magnified at the larger couch positions. So by performing these calibrations upfront for SRS, where we have really tight margins, it just ensures the accuracy from an end-to-end perspective. So again, here the vendor claims or what we say about the use of surface guidance in in SRS treatments. This is backed by clinical outcome data comparing the use of surface guidance and the more invasive traditional techniques. So you can see that there is evidence to support the use of surface guidance across a wide range of indications in stereotactic radiosurgery, from multiple metastases to benign indications. And there are sites as well which are treating trigeminal neuralgia cases with the use of an open face mask and SRS guidance. So why surface guidance for SRS and SBRT treatments? Again, backed by proven clinical outcomes in terms of accuracy and also patient survival and long-term patient outcomes. The treatment delivery is a lot faster. Again, we've seen some of these time savings with the accurate initial patient alignment. We also have the possibility to reduce those intermittent imaging that we would do to verify couch shifts, that the intermittent mid-CBCT, the end-CBCT, we can rely on the surface guidance following the initial CBCT throughout the entire delivery process. Again, for the patient, it's a comfortable experience, so we can improve that patient comfort while maintaining a high level of accuracy. So we can deliver these treatments using an open face mask, and like we said, for the patient, that's really a pleasant experience. And the same for SBRT treatments. We can reduce the amount of immobilization required. We can detect any meaningful motion during the actual treatment delivery, and we can monitor at all couch angles or couch positions. So just shifting the focus a little bit, like we mentioned, we are more familiar with your traditional CM Linux, which are completely open. But with the newer introductions with your Halcyon and Ethos Linux from Varian, these bore-based solutions, we now have a product which is the Align-RT in-bore component, which allows you not only to position your patient externally, so you will have the current 3-camera system like you've seen throughout the presentations here for the initial alignment. The patients can be positioned accurately in 6 degrees of freedom outside the bore, and then you can easily transition to the internal camera ring to ensure that we can still monitor the patients during treatment delivery. So again, there's a seamless integration or seamless flow from your external cameras into the in-bore component. Again, it allows, like we mentioned, initial alignment as well as the intrafraction motion management. And why do we need the ring? So we have one of the early adopters in France that was partnering with Vision RT throughout the entire development process. And we looked at, could you rely on just the external cameras for adequate interfraction motion management? And that's not possible because even with the adjusted position of the external cameras, you have this large wall or tunnel where it's not possible to get the full visualization of the patient's surface once they are at the isocenter position. So that is the reason why we have developed the ring, which has these small miniaturized cameras that give us the full visualization of the surface, and it allows us to treat techniques like DIBH and including SRS treatments in bore. So this is some data from a site in France looking at the use of Align RT for the initial setup, as well as the treatment delivery on the variant Halcyon. And here, the comparison was done between the traditional tattoo setup and the SGRT guided positioning. There was an improved overall postural correction and correction of the rotations before the CBCT imaging. There was also that improved efficiency or time saving with the end-to-end process lasting 6 to 8 minutes versus the traditional 10 to 15 minute session slot. And they have realized here that it is possible to, or they've concluded here, it's possible to rely just on the SGRT system and avoid those tattoos for the initial patient alignment. So again, improved setup positioning, which you will see on the next slide. You can see that the magnitude of the shifts and the distribution of the shifts are much more uniform with the use of SGRT. So again, just to summarize what we've been discussing here over these past few presentations and the use of SGRT, it allows an accurate and efficient treatment delivery process. We have the additional safety component of having the intrafraction motion management in all 6 degrees of freedom, and it improves the patient treatment experience. So for the patient, it's easy and it's quite a comfortable experience. For the therapist as well, the learning curve is very short. In most cases, after the initial training of 2 to 3 days, you can manage completely independently and you're able to use the system safely and efficiently. So I'm going to round up my presentation with the last 2 components. The one which I mentioned is, can SGRT be used during the pre-treatment or the initial simulation component? And then one topic that was mentioned in the previous Q&A was, can we visualize dose on the surface going forward? So we'll start at the pre-treatment or the simulation component. It is possible to have a single camera that is installed at the CT scanner. And what this allows you to do is simulate your patients, coach your patients in breath hold, also perform the breath hold scan using the SGRT technology, which is a single camera at the CT scanner, as well as your 4D CT acquisitions. So we interface with all 4 CT vendors, and here you can perform your 4D CT acquisitions. We will send the breathing information or the respiratory information over to the scanner to perform those reconstructions. So 2 uses here is your coaching and breath hold scanning, as well as your 4D CT acquisitions. Again, the advantage here is that we're using the patient's surface. We're using a virtual tracking point, so there's no blocks, there's no markers, there's no belt or any additional fiducials on the patient's surface itself. The feedback that we've had from the introduction of SGRT at the breath hold coaching component was that one of the sites in the UK, they have reduced their rescanning rate by introducing this coaching component and tracking of the breath hold scan at the CT. So again, why SGRT at the CT simulation? We can coach the patient into breath hold. They have the opportunity to use the coaching device so that they understand what is required later down the line when they come through for treatment. So you have this initial coaching, the patient is clearly informed of what it is that they need to do so that things go a lot smoother at the time of treatment delivery. It's completely non-contact, it's non-invasive, so we're really limiting the distractions of going into the room, adjusting stuff, placing anything on the patient itself. And like we mentioned here, you can easily acquire your breath hold scanning. There's a lot of functionality in here to ensure that the patient performs a reproducible breath hold, that they perform a breath hold for an adequate period of time. And then my last slides here is just this is what we are doing with SGRT at the moment, but what does the future look like? And we have just introduced now these Horizon cameras, which you will see here on our demo system as well. And these cameras are really laying the foundation for the future developments. So what will be available with these cameras specifically is they're Cherenkov imaging enabled. They are really high definition 8 megapixel, really wide field of view. And they also allow us to capture the entire body projection. So what does that mean in terms of radiotherapy going forward? Is can we now for the first time identify the dose that is delivered to the surface? So traditionally, we are obviously tracking the surface. We're using internal imaging. There's the in vivo dosimetry component, which you mentioned, but can we look at the dose that is delivered with visualization on the surface itself? And so for the first time ever, we do have that possibility now to track the patient, to monitor the patient, as well as identify the delivered dose as seen on the surface itself. So one of the sites in the US, which has been the early adopters of this technology, they have looked at can DOSE-RT enable the detection of any errors in the radiotherapy delivery process. And some of the identified errors here that would have been missed had we not used or had we not identified it through the dose visualization was incorrect bolus placement, MLC misplacements based on the planning itself, and then any overlapping overlapping treatment delivery as well, especially in breast onto the contralateral side, the chin if it was misaligned, or the arm position if it was misaligned. So now we have the ability as well to visualize the dose as well as the patient in real time. So how does this work? This is made available through these beam-side cameras, which is an exclusive partnership with VisionRT. And we use these high-sensitivity cameras to detect the Cherenkov light. So what happens when radiation interacts with tissue? It gives off this light blue light, which is not visually seen, but it can be detected by these cameras. The software then identifies this information and it builds a dose map in that treatment area. So you see the patient position, you see the delivered dose, as well as that information is stored for analysis at a later stage. So this is really, and that's what it looks like on the patient itself. So in a breast treatment, you will see that blue color wash display within the treatment area, which indicates the delivered treatment dose displayed on the surface itself. So that's basically how VisionRT continues to innovate and to develop within this SGRT space. So that's my final slide. I'd like to thank you for your attention. And a lot of the sessions today has been theoretic, but my colleague Irakli will be available after the final talk on the live system here. So feel free to interact with the system, to ask any questions, to see how it will be used on a live model. So you will see for yourself that it's quite simple and easy to use. So thanks again once more for your time, and I'm open for any questions.
Congratulations. Any question from the audience, please?
So thanks, first of all.
Pleasure.
I know that you have started collaborations with the ring systems as well as you have mentioned with the tomotherapy and with Halcyon. But do you have but as far as I know that you're only using it for setup right now for localization. Do you plan to implant a camera within the system during the treatment as well in the future? Do you plan to do that? Like, we're setting up the patient. We're using the system for that, but also we're tracking the patient throughout the treatment with the conventional Linux. Can we do that with the ring systems right now? Oh,
Correct.
it's
So-
available.
Yeah, so it's available at present, and we've had, I think there's 20 plus systems now installed and in clinical use. So the ring that is inserted into the bore is allowing for that intrafraction monitoring. So you have exactly the same as with the Linac, where you have that real-time information. And so good question. At the moment, it's a manual interrupt because at this stage, Varian does not allow any system or any third-party integration to hold the beam on the Halcyon itself. So it's not available for including their own product or any third-party system.
Any other question?
Hello, with regards to the Cherenkov radiation part with those RT, how exactly do you calibrate, let's say, the ISO center of those separate cameras to the ISO center of the machine?
So at this stage, the Align RT cameras are calibrated using our standard positioning, our standard calibration process. At this stage with the configuration, we're looking at 2 beam side cameras, also focusing at the isocenter position. I'm not 100% sure of the exact process for the calibration of those cameras itself.
Oh, okay.
So I can answer a little bit. So the calibration of the beam side cameras are the same as the normal cameras, optical ones, because they can capture the optical surface. So we utilize the calibration plates to define the external isocenter, and they can recognize the plate pattern and actually find the isocenter, so it can match to whatever the SGRT cameras are calibrated to. No, we need to, specific calibration for finding the isocenter or matching, let's say, the center with the Cherenkov cameras. Yes, it can be done with the plates, similar to normal SGRT cameras. For the cube, it's for the SGRT cameras because SGRT cameras also can track the position. Cherenkov cameras do not track the beam side cameras do not track the position, but they can actually capture the optical information. So you have the pattern and you can recognize the pattern and you can find where your eye center is with respect to your external positioning. Okay. Thank you.
Other questions?
Do you foresee development for MRI compatible? Because, for example, the ventricular tachycardia, I think you are safer with the MRI than to spot the septum and the small cameras in the heart.
Correct. Yeah, the resolution of the imaging is much higher, of course, with MRI for soft tissue. At this point, there's no real development that I'm aware of on the MR specific component, again, because it's got its own onboard video based technology. But yeah, nothing that I'm aware of at this stage.
Anybody else? Thank
Perfect.
you, Wes.
Thank you again. Take care.
So this brings us to the last presentation of the day before the demo. Artificial intelligence-driven real-time adaptive helical and robotic radiotherapy technology and treatment. I invite Mr. Imran.
Thanks. start. Thank you. This presentation, of course, will be totally different than what we had before, and our star, of course, Vision RT. But we just like to summarize what is new in Radizak and CyberKnife world, and in just 20 minutes, I think I'll try to sum up what is new and what's coming in the near future as well. So basically, the topic is start with AI, because as you know, is that these days the trend is AI, and everybody's talking about AI, and wherever you go to, and there are tons of presentations about artificial intelligence. But before start with the artificial intelligence, let's see how was the artificial intelligence in past or a decade ago, and it was a technology, and it was like a crawling baby. But these days, now artificial intelligence is so much, had a leap in the future. But what we are now is exactly this. So still a baby, but it's not crawling, but it's walking. So people just consider as that artificial intelligence take our jobs. It will do everything automatically. It will do planning. It will do contouring, everything itself. But it's maybe 2 decades far away from now, and it's not right now. But it's helping to radiation oncology and all the departments in the world. But if you look at the what is the most known artificial intelligence product is the Google's. Google created one artificial intelligence on the Twitter, and after 24 hours, that artificial intelligence tweet, as you can see, Hitler was right and I had Jews. So this indicates that still there is a huge leap to take in terms of artificial intelligence, but it will help us anyway. But we have to, of course, do our job and use our intelligence rather than artificial one. So let's talk about what is helical tomotherapy treatment, and I will mention first Radizak, what is new in the Radizak world. And helical tomotherapy treatment, just slow. Helical tomotherapy treatment is slightly different than arc treatment, because arc treatment is volumetric, as you know. But the helical tomotherapy treatment is similar to 3D printer. So as you can, imagine you treating slice by slice. So this is exactly the same. And during the treatment, you can also achieve 135 centimeter field of treatment. So it's a larger field. So what is Radizak? As you know, the Radizak just came a couple of years ago, 2 years maybe, and basically it's combination of tomotherapy and CyberKnife technology. And it takes the IMRT and helical approach from the tomotherapy and tracking feature from the CyberKnife. And before we start about those tracking feature and new features, I would like to mention about the beamline. What is the difference in terms of Linux? So as we mentioned earlier, there is a new trends on AI, IGRT, MR, these sort of things. These are the trends these days, but they are missing the most important part, which is the treatment part. Because what is the purpose of IGRT? If you think about it, what is the purpose of IGRT? We are doing a simulation. We are doing a simulation first. We do plan, and during the treatment, if we have even macroscopic IGRT, not the normal IGRT, but macroscopic IGRT, and if you watch individual cells, what you can achieve only this. Not the, it will allow us not to change this graph. This is dose volume graph, So if something goes wrong, the tissue will receive more dose, and you will lose the coverage. But if you even doesn't matter, you use Hubble telescope. This is what you can achieve. I mean, you cannot make it better. It's just allowing you not to change in the verse. So if you have a better machine, if you have a better capability, if you faster MLC, if you have a much better technology, you will end up better dose volume histogram, and then the IGRT will come. It will be provide you the help during the treatment. So let's look at the MLC comparison. So today's treatments are more dynamic, and it's rotating, everything is rotating, and everything is getting faster and faster. So the MLC speed has to be speed up. But now, as we look at the other vendors, they are stuck in the 5 and 6 centimeter per second. This is the fastest available right now. But if you look at the MLC of Radixact, the speed is 50 times faster than even the fastest MLC. There is a here you can see the comparison. This is 8 times slow motion, and this is Radixact MLC. As you can see, it's opening, it's closing, it's opening, but these still need to come and to travel the full length of the collimation. So this is very good comparison to what makes difference 50 times fast. So result, this is the Madame Curie dose distribution on the film. This is the real dose distribution. It's not a painting or it's not a Photoshop or anything. And this is the 120 MLC. And you can see the differences in terms of resolution or dose shaping. Basically, what is the purpose of the MLC? Is the dose shaping, right? So this is the real comparison of the. So let's talk about AI-guided real-time tumor tracking. So this is new. This is what is new about Radixact. I have a movie, and it's a good movie. I'm sure you already seen it. Most of you should have seen it, and it's a good comparison for what is gating, what is ITV treatment, what is tracking. So basically, the tracking is this. As the target moves, the linac moves. So there is no splash of water at all. You can consider water splash as a dose to surrounding. So if you treat ITV, if you don't have any technology, as you can see, there are many splash and there are many doses all around it. Because you don't have the gating or other technologies, so you have to treat longer, larger treatment area. Of course, you can use some immobilizations to cut some stable the patient, but still there is a movement outside and there is a splash of water, and which means there is a dose. This is the gating. You have a window. If it exceeds the window, it stops the dose, but still you have a ITV, smaller margin ITV. So ultimate solution is this, but this is hard to do. Why? Because you have to move the beams. You have to move the linac according to you have to get the information. So what we need to do tumor tracking? First, we have to manage to get the target position. It could be any imaging or artificial intelligence, doesn't matter. Then we have to move the physically the machine itself. So let's have a look first how we can detect the target position. So there was a, sorry. Actually, there was a movie here, KV imaging. Anyway, so basically there are two systems in the Radixact room. One optical camera, and it detects the movement of the LED markers. So you end up with seeing that this briefing cycle, and there is a KV, online KV inside the Radixact now, and this can get every 2 seconds new image. So you have a real image of internal imaging. And combination of those and artificial intelligence, you know the tumor position in real time, and you have an idea what will be in the future with the algorithm. Oops. Yeah, this is, now it's time to move to linac itself, because we know where the target is. Now, hard part. So if the tumor movement on the longitudinal superior inferior direction, as you can see, this is Y direction, superior inferior movement. If as the target moves on the superior, the jaws doing this. So it's just doing giving the tilts. Normally the treatment was not coplanar. There is a non-coplanar field, so it's a straight down. But during the movement, if it detects any movement on the superior direction, it moves the jaws synchronically. If there is a lateral movement, it only moves the patterns on the left and right. We can do it because we have 50 times faster MLC. The opening time is 10 milliseconds. So if the shift is on the right, it just closes one MLC here and opens another one here, and it takes only 10 milliseconds. It's very quick. But you can do it with the normal Linux MLCs. Why? Because it's too slow, and shifting the MLC pattern is not easy at all. And this is a real case, as you can see. This is one of the earliest treatment, 18 gray per fraction, and beam on time 9 minutes, and from door to door is 19 minutes. So it's rather quick. And now another thing, this is the just long announced in the last Astro, and it is SGRT, and it's helical fan beam KVCT. So it's not like a cone beam CT, but it's a real KVCT basically, and it can be used for even simulation purposes. And we used to have the MVCT, and now still we have an additional. We have KV source and KV detector, but is not a cone beam detector. It's a fan beam it will be fan beam, not cone beam. So it's a real CT, because what you see in the diagnostic systems, all the fan beam. So as you can see, it's rotating as normal. And what is the advantage of this? Of course, the time. It will take only 15 seconds to image in 20 cm. So if it's a 1 meter, it takes only 1 minute. So it's fastest imaging system, and it is normal simulation CT. And if you look at the dose, of course we don't want any dose, but the dose is given is 0.5 centigrade. If you compare with the cone beam CT, this is the lowest available cone beam CT. It's 10 times less, and even this dose less than normal sim CT dose. So you're giving during the sim CT, you're giving a little bit more than this dose. So this is also a comparison. So one of them is the simulation CT, one of them is the Radixac helical fan beam KVCT. So it's really hard to distinguish. You can distinguish this because it's used contrast. As you can see, CT simulation has a contrast, so you can see the differences, but it's exactly the same. So let's talk about adaptive. Now we have a real-time adaptive solution in near future. I will discuss about that. As MR doing on the table online adaptive, everyday new adaptive plan. So it's coming in the Radixac world. Let me mention about it. But first, I will talk about normal adaptive, what we are doing in Radixac world. It's automated adaptive, is already inside the system. What it does is, we take an everyday KVCT imaging, right? So this is everyday simulation. It's not IGRT, and those images can be used for dose calculation. So system automatically on the background, without touching it, calculates the dose every day. If today is, let's suppose, 16th of the day of the treatment, individual fraction has been calculated by itself and edits the dose, and the rest 14 dose has been just projected from the last day. So you end up with seeing a report. Basically, you don't have to even look at the dose volume histogram anymore. This is the left side is your original plan. And this is the situation now. The original plan, if left parotid is receiving almost 24, it's green flag because less than 25 centigrade, right? 26 gray. Now it's 27, so it's a red flag because it's more than 26. So even you don't need to look at the DVH anymore. You can see the anytime, any day, look at how the treatment is going. Do we need to adapt the plan or not? Because in old days, you just assume the dose has been escalated or changed, right? Why? Because the anatomy has been changed. You see from the patient anatomy. But now you have exact information, how much will be the PTV dose affected or how much the organ dose will affect it. So it makes you a more logical decision. And also additional information, it gives you report. In the report, every day's volume of each organ. It targets and also the some for example organs. For example, if it's a prostate case, you can see if the bladder and rectum is the same as every day. If you see this kind of pattern every day, it means that you're not producing the same fullness of the bladder or something like that. So it provides so much information about. And in the final day of the treatment, if this, let's suppose is the final day of the treatment, if you look at this report, it gives you exactly what you done. The first thing was a simulation. It's not the real world. This one is the only simulation. You just assume the dose will be like this. But now you have an everyday dose calculated because your IGRT image is the real KVCT and can be used for dose calculation. So end of the treatment, you can have a report of the real treatment. So you achieve good or not, if the organs, if you're expecting some side effects, something like that. What about future? So this is a little bit, we call it online treatment, but the real online in the field is considered as doing real treatment on the coach. So if you do every day on coach planning, it's an online on coach adaptive plan. So this is right now is only MR Linux can do it, and maybe some artificial intelligence ethos can do it. But Radizac right now two sites are doing on the on coach online adaptive. What they're doing is every day after the CT scan, there is a AI quickly calculates the dose, new plan, and everything being checked by the medical physicists and doctors and everything. Every day the new plan, the patient receives the new plan. Now it's almost 20-30 minutes door to door. But as you know, mRNAs normally 40 minutes, 45 minutes, even sometimes the 1 hour to whole process door to door. Now we are achieving 20-30 minutes. The target is 10 to 15 because this is not efficient. So not every clinic can achieve that everyday planning, right? So this coming soon. This is not available right now, but this coming soon, maybe next Astro, they will launch it. Let's talk about quick robotic surgery and CyberKnife new system S7, and also AI driven. There's a quick movie. So technology is evolving. Let's have a look to radiation therapy. 60s, 20s, 2010. So let's have a look to CyberKnife evolution. It started 2006 in Gate 3, and now we have 2020 and S7. What is the difference if you look at the treatment times? It used to be almost 1 hour, now it's almost 10 minutes in averaging. And the monitor unit is increased, and now it used to have only fixed collimation, then iris came, then MLC, so you can now treat any of those. It's all come with together MLC iris fix. And of course, it's doing the tracking. Tracking comes from the CyberKnife, and it's doing it tens of years. And what they're using is, as you know, is a diagonal KV source, real-time imaging, and the same artificial intelligence being used for the CyberKnife. And we know the target position and track the target position and treat So let's have a look to what is the purpose of the SRS. The purpose of the SRS is, rather than IMRT, is create a peak, because such a high dose, we have to make the dose gradient as high as possible, as quickly as possible. Drop the dose. To create it, you have to make a peak. So the general approach in the radiation therapy is you are not trying to get the peak, but what you're trying to achieve is just homogeneous dose. So this is what is the difference of the SRS and IMRT. To achieve this peak, yes, to achieve this peak, you have to use the sphere. If you think about the dose as a balloon, if you treating from the 2 dimensions, you can express from one side, and the balloon will get bigger on the other sides, right? So to get the balloon the smaller, all the around the target, you have to make 3D balloon. You have to use other part of so you have to spread the dose. Otherwise, there is no choice. To using the sphere, non-complanar sphere, this gives you the peak. But with the hyperarc solution, of course, you can somewhat you can use the sphere, but it's not as the total sphere. As you can see, you have a normal one plane, and you're adding 2 additional planes, and it's not a sphere. So still there is maybe you need tens of arcs. Maybe that time maybe it would be achievable. So if you look at the dose gradient, because of the design, between 2 and 5 millimeter, you can achieve the 100 to 50% dose distribution. Reaching between 2 and 5. If you look at the Linac-based hyperarc solutions, you end up being from 100% dose to 50% dose, around 4 to 8 millimeter. So this comes from this actually, because you're using the sphere and using even though you're using hyperarc, but it's not a full sphere. So if you consider the SRS, only SRS dedicated machine is CyberKnife and Gamma Knife, and IMRT dedicated, but also doing SRS, Radizak, Bayan, Elekta, all the other vendors. If you look at if you compare with them the cars, these are the Ferrari and Lamborghini, because they are dedicated this purpose, and they are high horsepower Jeep basically. So they can make speed, but they are not like a Ferrari or Lamborghini basically, because of the design. Thank you very much for your time. Any question? No, okay, thank you.
Okay, so if there are no questions, this concludes the talks, and then there'll be a demo for. $15 minutes? No. Yes. So it is a break of 10 minutes. If you would like a coffee or something before the demo starts.
workflow starts at the simulation first. So at the simulation, we recommend you capture or you scan the patient twice, once in free breathing, when the patient is completely relaxed on the table. We'll utilize the scan and the reference from that scan to set up the patient initially on the table. So we utilize this surface as for initial setup. And of course, we perform the DIBH scan, where we're doing your dosimetry, and DIBH scan we use for automatic default and for DIBH delivery in all 6 degrees of freedom. So what you see here, I'm live monitoring my patient here. So I'm seeing the live video feed coming from the cameras, and there's two parts of information here. First of all, on the right side, you see the post-show video. The post-show video is the live feed coming from our horizon cameras overlaid on top with the PIN guidelines. So the PIN guidelines are automatically generated off your reference surface. So whatever way you scan your patient at the simulation, we are repeating the same geometry right at the setup, from the first fraction to the last fraction. Here, I'm looking at my patient, and I'm utilizing my free breathing setup here. So you see my free breathing surface is set up. I'm looking his alignment on the table. First of all, I can also cycle between the cameras. So I can go to one of the ladder cameras, or I can go to one of the cameras at the foot of the couch, see what's happening there. So immediately I could see if my position is the same as I had at the simulation, if he's rotated, if there's any inherent rotations to the torso. If I look at one of the ladder cameras, I can also detect if he has some kind of a pitch associated to him. And if I also need to look at the details of his alignment, minute details, I can always also zoom in into my view. So I can see, okay, maybe he has kind of tilted a little bit to the side, and I can correct for that as well. So you have a possibility to look in for the details. And this is also a great tool for interfraction monitoring. While you're delivering the radiation, you will immediately know if you zoom in at your treatment area, at your interest area, you can see if there's any, let's say, interfraction motion going on. For example, some of my, let's say, end users that utilize Align RT for treatment, they even utilize this post-show video and the outlines to watch for the swallowing for the Bucharest patients. They look at the suprasternal notch and see if it moves during the treatment, because they're delivering those treatments with BMAT or IMRT type of radiation delivery. So you can even see those minute things. But first and foremost, this is really for global positioning. Here, immediately I see there's a few, let's say, inherent problems with his positioning. His arms are not in the correct place. Actually not in the same position that was at the simulation. I see they're a little bit tucked in a little bit, so maybe I can go in ahead, just looking at the screen at the same time, and maybe try to correct it a little bit. And as soon as you're correcting, you're also seeing this information in real time. So I'm going to go ahead, raise this arm a little bit, make sure it fits, and you can always correct for this types of arm positioning. On top of this, you also have your deltas. So real-time delta feedback is there. So real-time deltas are presented in all 6 degrees of freedom that tell you in which way you have to move your patient to align your patient at the isocenter level. So all the deltas in all 6 degrees of freedom are always calculated and displayed with respect to your isocenter. And since the system usually has the feedback back to the linear accelerator, you can drive the couch automatically. So you can take those deltas, you can send them to your robotic couch, and the couch can move automatically to the isocenter. So you don't need the need to manually, let's say, tug or free float the couch to basically put the patient at the isocenter. A lot of our centers that utilize tattoo-less and marker-less setup and quick and efficient setup use this kind of workflow. They go in, turn on the live monitoring, immediately bring the patient to appropriate, let's say, treatment area. If you're treating the left breast, you just bring in the patient close to the left breast area. They see the deltas, they align the posture, and they don't even bother manually adjusting the table. They take the deltas, send them to the couch, and couch then does the work for them. So a lot of our reference centers, they use quick workflow. They can set up the patients under 1 minute, utilizing this workflow without any marks to do such a time. So you can utilize full 6 of patient setup. So now I'm looking at the deltas here. I see the deltas are also fluctuating. It's, of course, my patient is breathing. I'm seeing some of the breathing motion as well. And when I'm happy with the setup, I see a little bit of a vertical shift here, but it's fine for me for now. Of course, if I had a robotic couch, I can also correct for that as well. So I can move the couch a little bit vertically down. So if I'm happy with my setup, I see there's no inherent rotations going on here. The translations are pretty much okay. I can go ahead and switch to my breath hold surface. So as soon as I go into my breath hold surface, I see my deltas are exactly out of tolerance. To kind of visualize this a little bit better, I'm going to go to the lateral view to let you see where the chest wall is and where it needs to go. So now, let me see if it turns on. Sometimes it turns off, it's not used for a long period of time. So this is my coaching device. Ooh. Okay, let me try to re-exit. Okay. So slow it's not going to work during the demonstration. So normally, of course, we would this is DIBH, let's say amplitude, or how much they need to inhale and hold, would be usually dictated by the visual coaching device. So in the visual coaching device, you can visualize this bar. So you see the yellow bar in the white space. And when the bar actually achieves the white area, the patient knows they're at the breath hold, you can hold, and the bar turns to green, and the treatment can continue. So I'm going to go into my video display back, and I'm going to now ask Ocean, our patient, to take a deep breath and hold. Again, inhale through the nose and hold. Relax. You can go ahead and inhale and hold. You can go ahead and relax. So what I'm seeing here is the discrepancy between here in the bar, the vertical position of the chest wall, and the white area that I'm seeing is my, let's say, a threshold. The threshold can be set individually for all 6 degrees of freedom. So by default, for the breast, it sets at 3 millimeters and 3 degrees. But you can modify this specifically for different treatment sites you want. You can modify it for per patient, or even modify it and change it per fraction as well. You have a possibility to do it. So I can, for example, even make it smaller if I want to make sure that it's, let's say, harder my patient to achieve a vertical displacement. And you can see also the bar, the white area became smaller as a modified threshold. So normally for chest wall treatments, the breast treatments, gallery treatments, it's set at 3 and 3 millimeters and 3 degrees. For head and neck treatments, for SGRT treatments, it's set at 2 and 2 by default. And for SRS treatments, it's set at 1 millimeter and 1. So if patient moves outside of that threshold, the beam will be automatically stopped because there is a feedback connection to the linac. And even if you have a single degree of freedom outside of tolerance, the beam will not be on. So I'm going to again try to ask my patient to go into the breath hold. Inhale through the nose and hold. You see now the deltas are within the tolerance, and the treatment can continue as it is. So if I have, let's say, a beam control option, the beam control option will be toggled on and beam will be automatically resumed. Okay, you can relax, exhale. Two more things we mentioned here. The first and foremost is my surface deformation. If I have any particular changes associated with the surface, I can visualize this as well. If I have some kind of swelling and some kind of, let's say, weight loss or receding surface as well, you will have a color overlay on top of this. You will have sometimes a red overlay if you have a swelling, or you have, let's say, blue overlay if it's a receding surface. We can quantify this here as well. So in my case, I can say, let's say, about 95% of my target area is within a 3 millimeter tolerance. So I can quantify those changes and understand if I need to modify anything in a dosimetry way. Let me enable the beam hold, automatic beam hold for this particular treatment. I'm going to go into the preparation and turn this possibility here. So in a preparation, I can indicate if I have a surface that's utilized for automatic beam hold gating. So in my case, I will select treat with beam control type of surface. And when I go back to treatment, when I start monitoring, the beam control toggle is on. So I can toggle this automatically. So there's a feedback connection, again, back to the linac. Since we see the deltas are out of tolerance, beam is automatically held. I can go ahead and coach my patient to go back into the beam hold. So again, inhale through the nose and hold. As soon as all the deltas are within the tolerance, the beam is automatically enabled by aligner T. Okay, you can go out and relax. All of this data you see, all of the real-time deltas, are actually displayed with a very high speed. So now at this point, we are updating our position or the match of the patient, this fusion in real time, about 20 times per second. It's indicated here at your treatment console. So we are basically monitoring this position with a very high accuracy. On top of that, we are also saving all this data for the patient treatment session. So if you want to do any kind of retrospective analysis on the patient, all this, let's say, 6 degrees of freedom monitoring of the patient's position is available for you as a patient report. So you can always pull it up back for the patient treatment session, or can actually take it out as a number and do a retrospective analysis on it. Any questions associated with DIPH treatments or how this can be facilitated?
What about the CT simulation solution? So here we can see the hardware for the criminal ring.
Yes.
So regarding the CT, how can we be sure that the patient will be inspired? Will we use the same hardware?
So first of all, there's a possibility to have a single camera system at the CT center. Okay. if there's no respiratory management device on the CT. So the single camera system is again mounted to the ceiling, and it's looking down to the bore. It captures the patient surface. It's a contactless solution. And on the patient surface, you can select respiration, let's say, points or patch, either on the thorax area or on the abdomen area. And with this, you can do the coaching. So similar kind of coaching. You make sure when the patient inhales and holds, the amplitude for the deep hold or the holding of the breath is stable. And you can do this kind of during that period of time. You can utilize any other device as well for the DIDH coaching if you have something else on the CT set. But if you don't have any other external device for respiratory management, the SIMRT is a good contactless choice as well.
Okay. This camera can be also used for DCT reconstructions?
Yes. So the camera, because we record the respiratory signal, we can utilize this for 4DCT reconstruction workflow. We can record the signal together with the X-ray signal, and we can send them this data if your CT cell console accepts the data as a.
Do we have an interface with all the CTs?
Yes, we have interface with all the available CTs. We believe all the vendors are, let's say, compatible with us, whether this is Siemens, GE, Canon, Toshiba, what else is there? Stanford Imaging as well, and so on. So all of those CTs are compatible. So for CTs, we utilize the same connection, so a single connection to the CT, and we can utilize the system as external interface. But as the peace of mind goes, the reference that we use for the DIDH or for treatment in the console is the diaphragm surface. So whatever surface you generate in your treatment planning system, we utilize this as our reference. So we don't need to have a camera to capture the patient's reference at the CT. We can utilize the diaphragm information and geometry from the diaphragm to facilitate those references. More or less. Okay. You can take down your hands. No, don't get out first. Just hands. Just hands. So what I'm going to do now is try to see if I can now show you what it looks like for the head or for the cranial SRS treatments. I'm going to leave my treatment workflow and go back to my, let's say, patient list. So I'm going to pull up the SRS treatment plan and see, let's say, how this treatment is facilitated here. Immediately, you can see the region of interest here is different. So for the region of interest, we are actually tracking the opening in the mask, so this open face mask. Usually the minimum recommended opening we tell our users to incorporate into their simulation workflows is about 2-3 centimeters above the eyebrows, going down to the, let's say, upper lip, and maybe to the outer canthus right here. So basically about this opening is about the minimal size recommended. There are masks with larger opening, like the one presented here that we've molded here that has a larger opening into the face. So it's just basically just the forehead and chin mobilization. So, and you can treat patients with large openings like this. Their clinical publications, they treated patients for trigeminal neuralgia, single fraction treatments, 80 to 90 grade with open face masks like this, with a very good clinical outcomes. And SGRT based setup methods. Okay, so I'm going to go ahead and show you what the SRS type of workflow looks like. So it's quite similar. We start from, let's say, my postural video. So I'm going to go ahead and start monitoring. I have a little bit of a shift here. So my patient is not aligned well. So of course, I cannot move my static table. But here with the postural video, I can see where the head is, if it's rotated or not. I can look at the cameras from, let's say, foot of the couch. I can see, okay, maybe his head is a little bit tilted. the inherent roll a little bit, I can go ahead, looking at the roll, and just manually correct it as I am, let's say, looking at my portfolio. And you see, all those adjustments that I'm doing in real time are also indicated down there in your real-time deltas, since we're updating the position again in the real time. If I have, again, additional pitch of the roll, I can go ahead, adjust his cranial position. If I have the pitch, for example, or if I have the roll, I can go ahead and adjust, or if I have rotation for the head. Okay. So you can see how easy and quick it is to actually adjust for that cranial locations, which is a very, say, tedious thing to adjust with just under the mask. Even before I put the mask on top of my patient, I can go ahead and change for those, let's say, for those rotations in real time before even putting the mobilization for the patient. All other translations, for example, I can utilize a connection to the Linux to send the translations to the table itself. So don't even need to, let's say, manually pre-plot the couch, move the table, and I can drive the table directly to the ICU. Since I cannot do it right now, I will capture a new reference surface, which is, let's say, a normal workflow post-imaging. So SGRT works really well with IGRT together as within the hybrid workflow, because we utilize the SGRT for markerless, tattooless real-time positioning. With IGRT, we can do our, let's say, IGRT, we can do our, let's say, verification with your internal imaging, so we can make sure everything is set up. Let's say we can match with our internal anatomy, we can match with our bony structures. And when I'm happy with my match, and when I'm happy with our small table motions that I do post-initial positioning, I can always capture any reference surface after the IGRT workflow. So this new reference surface will actually zero out my deltas. Let me try again. So my new reference capture will zero out my deltas. So this is the position that I verified with my IGRT, with my CBCT, for example, for SRS workflows. And now I can track my patient with respect to this position in real time. So even if I have, let's say, non-complanar treatment where I need to rotate the couch, I can track this position in real time even for that non-complanar areas. Because, for example, if I have a rotation, I don't have now the plan, but I'm going to just add rotation, let's say 45-degree rotation to the plan. You see, let's say, my capture reference is rotated according to my plan value. And as I'm moving the table to a non-planar value, I'm going to see my rotations or my yaw decreasing in real time as the patient moves into the position. So that gives me an idea of how to track the patient, and I can track the patient again with the same accuracy that was mentioned during the big session, which is less than 0.3 millimeters and 0.2 degrees. And that includes all challenging positions for the gantry and the table. Even if you swing the table to land with the angle, if your gantry comes in and blocks one of the other cameras, with two other cameras, you maintain the same tracking accuracy for those challenging non-compliant exercises. And of course, now it started working, so I see my coaching device as well. And I see my vertical position change if my vertical changes. But you see my patient is moving as well. And for the DIBH, the patient will see that screen in front of it. It's again mounted to the flexible gooseneck. You can bend it in any direction. You can attach it to the table, or you can attach it to your board. And what you see is actually the same vertical threshold with the bar that indicates the vertical reading. Patient goes into the breath hold, the bar, which is the white area, and the patient knows that he inhaled enough and the treatment can continue. That's all. Any questions concerning SRS or DID protocols?
CRS. Why would this be better than mask with a mouthpiece?
Why this would be better in a mask with a mouthpiece? Yes, I've used prior to SGRT. Before I used SGRT, I used the masks with a mouthpiece, open face masks with a mouthpiece from a particular vendor. They are better than without. I mean, if you don't use the mouthpiece, with a mouthpiece that give you a better immobilization for the cranial tilt, but they don't fully correct for the roll or any kind of little bit of rotation as well. So you have inherent changes in initial position that translate into your rotations post-mortem. So actually, if you position the head first exactly, then you, let's say, put on your mask with the mouthpiece, open face mask, you will see a bit of a cranial change as well, considering how patient bites down on that mouthpiece, because that can change a little bit. And you can see it in real time as well. So you can position the patient first without the mask, as close to reference as possible. You can put down the mask with the mouthpiece. You bite down on the mask. It changes a little bit the cranial posture, and you can modify it, you can adjust it prior to the imaging, even before doing the CBCT. So with just doing the open face mask or closed face mask with the mouthpiece, you have inherent rotations that you cannot, let's say, fully adjust or fully correct without SGRT. So I've used that prior to ones, and I've had rotations sometimes exceeding 2 degrees, even with a mouthpiece. So normally I had rotations exceeded close to 1 degree or so. It's better than just with a mask to have a mouthpiece, but SGRT, positioning, monitoring, and pre-correction, say, part of CBCT, I think is the best compared to everything else.
I have a question.
Yes.
Since we cannot simulate the patient with the couch chamber, I assume that when we enter the angle for the couch, it reconstructs using the data that included we have in the simulation, or how does it come?
Yeah, so I think I forgot the microphone. So it can, yes, yeah. They gave me the microphone, forgot it. So first of all, it takes that reference. So the reference, as I mentioned, can be coming from your DICOM surface. So whatever way you had the surface simulation. So, or it can be captured by the cameras, either way. So when we have the planned rotation inside the plan for non-coplanar angle, it will rotate that reference with the same angle as you had inside the plan. So if this is, let's say, post-imaging, this is the captured surface that was captured and corrected by the CBCT at the angle 0. Then I go non-coplanar, I cannot do any imaging anymore, but I have that reference that was matched to the CBCT IGRT match. And with a reference, I can rotate to the same angle, planned angle, and I can check whether the patient's position, especially for the cranial head, which is a very good, stable, rigid surface compared to the head, I can check if that position actually corresponds to what to what I had at the 0 match. So we rotate with the same angle that's planned. We had many customers, they utilize the line RT for positioning. They rotate the couch, they see a bit of a discrepancy. They are wary about this. And in the end, it turns out that is actually a couch walkout that they were not aware of before. So the system is, again, very accurate. It can detect those small changes. We had a customer in Germany. By the way, if there was a very nice SGRT webinar series called SGR Tuesdays that just finished. It's available on demand on SGRT community as well. The customer from Germany doing, let's say, non-compliant SRS in the bunker, they were sure that their couch was good and everything was well enough. And at some point, they found out they had a walkout, and they were very skeptical. In the end, they found out that the construction next site, so new building was built like right next to the bunkers, actually caused the vibrations from construction caused the table to drift a little bit. So they corrected this in the end. So those things you can catch. We've seen some drifts also post earthquakes. So earthquakes are not coming here, but Japan, Southeast Asia, that happens. So it's very sensitive. So it's as sensitive as your thickness of your piece of paper. So you can detect very, very small changes. Even here, if I go back to my surface, you see I removed his eyes from the region of interest, because even his blinking could actually be picked up by the camera's position just of his eyelids. So this is one of the, let's say, tricks one of our end users utilize to check for patient positioning or to have the accurate position for the cranium. Okay. I think you're free to go. Okay, another round of applause for Lucian. Thank you. Sorry? Yes, so, how can I adjust it? Yes. So, it's like, actually it's pretty similar to Microsoft Paint. So you have a painting possibilities, so you draw it. So here you have your region of interest. You can either start with a completely new one, or you can modify existing one. So you can add, let's say, a new region of interest or edit the existing one. First of all, here's your, let me get the one with a mask. I had one with a mask, right? Yes. First of all, good thing is I have here the 3D photo feature. So a 3D photo feature, when I capture a new surface, it overlays actually the physical features of the patient on top of my surface. So I know where the opening of the mask is, where the mask starts and where it ends, and if there are any, let's say, facial hair I need to be worried about, or any kind of non-reproducible surface I do not want to include into my region of interest. So now I'm into my ROI editing mode. So I usually have two tools here, rectangular tool, oval tool, and a freehand tool. So they work in the same manner. Rectangular on oval tool can add large areas of, let's say, region of interest into the region of interest. So I'm gonna kind of show you a little bit. So control left click will add whatever was within the selection into my region of interest. And control right click will erase whatever was inside the selection. The same way it works with the oval. And so on. If I don't like some of my changes, I can always undo it. Or I can always reset the region of interest to an initial, let's say, initial area. And of course, I have the freehand tool, which I find the very useful one. So the freehand tool is really is a brush tool. So gives you idea to freely manipulate region of interest as much as you want. So you have brushes of 3 different sizes. I believe the largest one is the most useful to me. So I utilize the largest one very frequently. I take it. And then the same principle works. Control left click to draw or add, and control right click to erase. I'm going to show you a little bit. So I removed his eyelid. Or I can add it back again. So it's up to me. So you have a full free control, how to draw it, where to end, if you want to include facial area, if you want to add some, let's say, go farther down. You see here where the mask stops, okay? I see here some of my region of interest goes on top of the mask. I don't like it, so I can go and erase this area. And I can always manipulate my region of interest in any way you want. So normally when you capture a new reference, the region of interest is mathematically propagated from your original surface to a new reference surface. If you believe that you need to change a bit of propagation or adjust region of interest, those tools are always there for you, and you can directly do it into the treatment. You don't need to go into the preparation mode or do anything like this. Okay? And anybody wants to give it a hand, you're welcome to go in and try yourself how is it is. Ok. Mulțumesc. And yes, you can try your hand at it. So it's not just for me. You can also try going to the menus, see what's happening. It's free to use. You can break it. Yes, so this is the mock-up of the indoor ring. So there are no cameras inside. This is just the plastic housing shell. So this is what it looks like, and this is the clamp.
Yeah, that's
So this is what actually expands the ring into the bore, and I can use it and remove it afterwards. Just to give you the dimensions and size and everything. And here are your cameras. So see, it says 2 camera units. So these are stereoscopic cameras. So 1, 2. So 1 stereoscopic camera, and 3 and 4, a second stereoscopic camera.
How about rotation when you first mount it? How do you adjust it?
It has a crosshairs here, so you can utilize the laser to adjust it. But actually, you calibrate it. So when you remove it when you remove it and put it back, you calibrate it because you want it millimetric, right? So there's no way to fit it, within a millimeter. So every time you remove it and put it back, you calibrate it and utilize this plate. Yes, so it's 70 by 70. Okay, sorry. Yes, so it's 70 by 70. So you have the crosshairs here. So that's your gantry direction. You align it according to the lasers or the field lights if you want to see on LIDAC. And you just capture let's say, the picture of this plate. And then what you need to do for initial calibration, you have to just select the main blocks that marked with the numbers 1, 2, 3, and 4. And all the other ones are automatically identified by the system. So then it knows where the eye center is, and it sets the optical eye center here.
What do you mean by selecting them? Is there anything you have to do, like select their position exactly or dimensions?
So it's just on the picture because the cameras capture the pictures of the plates, right? So you have 2 pictures per pod. You because you have two cameras. So what it initially wants you to define the isocenter position for the cameras. So in every picture, on all those this 6 pictures, the very first time you install the system, it asks you to basically select those 4 points just on a picture. Just basically, it's
I get it.
and
I get
nothing
it.
like
It's
less
just-
mouse click.
Okay, okay. I thought you have to maybe give certain dimensions from the isocenter or something like that. Okay.
So next time you want to recalibrate, because it knows where the isocenter is, it will find them automatically. So you just need to do it at the installation stage. So then it will find the place itself. Let's actually do a calibration. I think they put it on, yes, on this box. Kind of put it close to the center. I don't have the lasers or the light course. So it's going to be all red when I calibrate it. But I'm going to show you how easy it is to do it in real time. I'm going to exit from here. So to go here, I have the daily QA and the system calibration. For system calibration, I can calibrate with a plate and with a cube. So first of all, I'm going to go and set up with a plate. So this tells me how to set up the plate. It tells me position the plate there, 100 SSD, treatment, room lighting level, everything like this, positioned well enough. The arrow needs to be in. Everything's well. And then when we were happy, make sure nobody's blocking the camera views to the plate. I'm going to go and start calibration.
Sorry, 1 second. Do you need any more model? Do you need any more model?
No, just calibrating. I don't see a picture.
So basically this is an anomaly, like it's not making the line over here. I mean, it should be a full rectangle when you are capturing the correct.
Go a little bit up by this, because field of view are over here. So.
Okay.
I moved it. Yes. Okay. Okay, so you see there's a really big difference here because I don't have any lasers. And 2 things here. So the very first time you open it, it will tell you to select those 4 points. Now, if they are not selected properly, you can always go in and reselect them. So for this, you double click to enlarge it, right click to clear selection, and then 1, 2, 3, 4. So that's what you have to do at the initial calibration.
Okay, question here. When you select the point, does it matter where exactly you click?
Inside the circle.
So just as long as it's inside?
Yes, inside the circle. It doesn't need to be exactly center because it finds the centers automatically.
Okay.
Yeah, that's what I was.
And then you will find all the other blocks with respect to those 4 main ones automatically. You even see there like small crosshairs inside each one of them. Okay? So as I mentioned, you have to do it only once at the initial calibration. Next time you position the plates and calibrate, it will give you deltas. There are 2 things you're going to see in the plate calibration. First of all, is compared to prior calibration. There is a big difference in vertical, longitudinal here. Of course, rotation is there. But since the table knows rolling the pitch, the table is quite level. What's important though here is the pod positions. It actually checks if the camera pods are stable. So if somebody moved them or not. So what you see here is the relative displacements between pod 1 and 2. So 1 and 2. So these are the lateral ones. 1 and 3, 1 and 3. These are the displacement towards 1 and 2 and 3. So 2 and 3. So let's say somebody moved the pod 1, right? Somebody moved the pod 1. So this number and this number would be out of tolerance and rise. So now you immediately know that pod 1 has moved. Maybe somebody bumped cameras or somebody was doing the ceiling works and then they hit the ladder.
Does it tell you without going into the calibration?
Like in
Or
the
does it
daily
only tell you
QA.
after
Yes, the daily QA will fail. So if you have a significant camera motion, every time when you perform the daily QA in the morning, by the way, it's mandatory, and it has the timestamp of 24 hours. So you do it once in the morning, they can utilize the system for 24 hours. So if somebody changed something, you come in the morning, do daily QA, it fails, and you can then perform the calibration, check something happened, and you would immediately see the camera signal. By the way, you don't need to apply the calibration. You can always cancel out. It's counted as incomplete calibration. It retains the prior isocenter. It's a good tool to do, let's say, a monthly QA check on parameters of the cameras. So if you're performing, let's say, TG142 tests or seeing how stable your cameras are, you can always put the plate on the table, just go into the calibration, check that everything makes sense, they're within the tolerance. If you're happy, you don't need to recalibrate. You can always cancel out. But even if you cancel out, there's a report saved into your system. So you always have those numbers available to you. You can just pull up and see what happened during those checks. So you have those available to you.
So what happens during the day? So you already did the daily game in order to wait for the next day. What happens?
If somebody with the camera, I can always recalibrate any point of time.
But so it doesn't tell you. You have to figure it out yourself. So how do you do it like that?
You figure it out the next day, same thing as.
Yeah. So let's say it happened midday. That's the question.
No, somebody moved the camera and they didn't tell you if they moved the camera. You will see a discrepancy there. So your numbers will not make sense. So first of all, you will see discrepancy in your postural video. When you're treating the patients, you will see your postural video is shifted. So you will see the view from one of the cameras shifted while two other cameras are okay. So you would immediately gives you the idea that your camera has moved. And the deltas will also be unstable as well. So deltas will give you the idea that something's coming wrong. But the postural video is the best kind of indication for this, that somebody really moved the camera, I didn't tell you.
Yeah, I was asking
Camera.
you if there is a opportunity to do this while not having the patient on the table. You know, doing prior to putting the patient on the table and say, okay, we need to do the calibration. You know, maybe you have to get out of the room. We do the calibration, then I put you again on the table and restart.
Yes, you can always do it with a phantom though. There is no collision detection on this one, on those cameras. There's a collision detection on this inside board though. So there's a sensor for small cameras. So if something really hit those small cameras and they shift the position, there is a sensor that tells you that they've moved. Here, they don't have the sensor, but honestly, they are also bolted down on the ceiling. So it's really not that easy to move the cameras. You can even check. You know?
Okay, I can see it returns to the.
So it's not really that easy. I mean, you have to really force it or hit it with the heavy thing to really, change position. But you can, I mean, if your daily QA fails, if you believe the cameras have moved, you can always check the system. And it's quite easy to do it. So for me, I can go ahead and just click on recalibrated. So I've updated my calibration. So every time you change the isocenter, daily QA is mandatory to be performed afterwards. So daily QA is the same process. Make sure nobody's blocking the cameras. Sorry. daily QA same process. I'm going to start daily QA. Again, position the plate at the eye center, 100 SSD, and it checks my positioning here. Yeah. Let me see why it failed.
Maybe because it got the baseline from the core version, the calibration.
Let me start calibration. Yes, because I moved the cameras. See? Yeah, I moved the camera number 1.
So it actually was enough to.
Yes, because of course they are on the tussles now. So,
Yeah.
So they're not bolted down on the ceiling, so it's easier to move them.
And also are they numbered?
Yes. So sorry, this is the number 1.
You know it is the number 1. That's what I was depends. Only with the so not the physical aspect of it, but only for the.
Yes.
I mean, if you really want to, you can.
Just
also
for the naming. So historical naming. They, for example, 20 years ago we had a 2-camera system. So it was camera number 1, camera number 2. And they added the 3rd one, so this is the 3rd.
Okay.
So this is because of the historical.
I thought maybe they would put a small number or something like it, just for.
No, you can label it.
Yeah, if you have problem in the sentence, like this.
No, I can just do like a small label.
Post thing like that.
Okay. So again, the daily QA shows you the RMS value and also shows you the trend line. So you have a trend line of daily QA RMSs. And you can see if you have, say, the trend line is increasing or something is happening to it. You can display the date range from 4 days to 14 days here. So all of those will be, let's say, distinguished here. The fail threshold for daily QA is 1 millimeter. So if it's over 1 millimeter, the daily QA will fail. So we'll ask you to repeat the calibration or make sure the plate is positioned well. And if it fails and you believe it's because of positioning, most of the times it's vertical. In reality, we've seen sometimes vertical positioning is different because different clinics position differently. Some use the ODI, which is not very accurate for, to position the plate with under 1 millimeter on vertical. So ODI is not very precise. Sometimes it's vertical usually. So you can adjust, make sure the vertical is correct, and then you can even repeat the capture. And when your daily QA passes, you can just click done, and that's it. So daily QA is, again, we can finish in 2 minutes. Put it here on the table, 100 SSD, alongside the lasers or field lights. Click one button, capture, done.
It's done. Yeah, it's actually pretty simple.